and all. Here we are with our series number 28. Yes, that's humongous. Series number 28. अब एक छोटा सा गाना गा रही हूँ मैं. Now just guess, we always do all this in association with one of the chapters other than our own Vidarbh chapter. So this time, IFS Vidarbh chapter along with IFS Punjab chapter, here we are in association with NOGS, that is Nagpur OBGYN Society, welcoming you all. I, Dr. Parul Sauji, along with my colleague and a very dear friend, Dr. Neha, welcome you all. For the series number 28, that is Understanding the Molecule in IVF Stimulation Protocol. So here, the two of us are there to entertain you and to take you further from this point. I welcome all the dignitaries for the lamp lighting. So are you all ready for the Maharashtrian thecha with the Punjabi tadka? So first of all, let us all invite somebody who's full of dynamism, life, energy, spirit, liveliness. I was just going through the synonyms of charm and lively, and I was falling short of the words which we need to describe this wonderful lady who is full of charm, amulet, talisman, fetish. I'm falling short of words, ma'am. Here we welcome Dr. Sushma Deshmukh, who is the secretary of IFS Vidarbh chapter, also the president of Nagpur OBGYN Society, for her always that, pep talk. I can actually, ma'am, sing a song for you, which is Tum aa gaye ho,
My God, Parul.
tum aa gaya hai. And I'm sure, ma'am, every one of us very well agree, because I was hearing you and ma'am talk that, you two have done a panel and everything, and you were like brilliantly charismatic even then. So here where I am welcoming you on the Zoom platform, and our dil is going zoom, zoom, zoom for welcoming you for your pep talk.
Sure. Thank you, Parul. Really, we need to be zoom, zoom, zoom with this different type of webinar. So respected seniors, friends and faculties and all who are gathered here for this wonderful webinar. So I would like to say, because every month we are coming with different concepts. This time I was thinking in a different way. Though I am as a NOGS president, I was really busy. But I was thinking we'll have some discussion regarding some molecules and like that. And when I was thinking, suddenly I received a call from Sarabjit Kaur. Okay, ma'am, we can have such a webinar like that. So it was, like a telepathy. I was so surprised, really. What a wonderful thing he was asking me. So immediately we decided, and really he worked very hard to organize this webinar. And so that's why we all are here gathered here to have this wonderful webinar. Always I remember one thing that from a quote of respected Ratan Tata, that's I don't believe in taking right decisions, but I take decisions and make them right. In the same way, when we are using drugs, we don't believe in others. We try on our patients, because the patient can be of different categories. So we have to select the patient category of the drugs and the doses. And according to, we have to work in a different way to have a good results of the pregnancy. So here, I welcome you all to listen this wonderful seminar, a different kind, there's understanding the molecules in IVF and stimulation protocols, which is very much dear to everyone's heart. Thank you.
Thank you so much, ma'am, for your wonderful welcome address. Now I request our Tunak Tun director, our Dr. Sarabjit Singh sir, who will be giving welcome address. As we all know him, he is a director and consultant of reproductive medicine and OBGY of Dove Art Bank, Jalandhar. So I request you, sir, to please give welcome address.
Thank you. I hope I am audible to everyone.
Yes, sir. Yes, sir.
So it is so wonderful actually to connect again with IFS Vidarbha chapter. It's full of energy. You know, these all the girls, the ladies, everyone over there. So on behalf of IFS Central Team, IFS Punjab and IFS Vidarbha, I welcome you all to this nice platform where we'll be discussing the molecules. I'm not able to reach to my station, but you know, the beauty of these webinars is you can have, you know, your coffee in your hand and you can be at any place and still can join and learn new things. So thank you, IFS Vidarbha chapter led by Dr. Sushma ma'am and everybody else who have put their efforts. Let the game begin. Thank you, everyone. Over to you, dear Neha. Thank you.
Thank you, sir. So we request our chairpersons will start as soon as possible now. We won't be wasting our time. So we'll be welcoming our chairpersons for our first session.
So as we've already described, and
No,
this
it's okay.
wonderful
We'll
lady
start.
right here, Sushma ma'am, who actually said it very rightly that, you know, you don't take the right decisions, but you make them right. So we already know that she's been taking all the right decisions, and obviously all her decisions which she has made are right. So ma'am, welcome you for being the chairperson for the next session.
And I also welcome Dr. Neha Lad ma'am, who is a leading IVF specialist of Nasik. So welcome ma'am, welcome to the session.
Welcome.
Dr. Neha join.
Yes, I have
Yeah,
joined.
yeah.
Can you hear
Thank
me?
you. Yeah, yes.
Yes, ma'am, we can hear you.
Thank you.
Thank you very much. Welcome.
Yeah.
So we would
So
request
shall we
one
start?
of the chairpersons, to introduce our speaker for today, the first speaker who's going to be talking about everything and anything about letrozole.
Thank you very much. Just I was describing you how I was thinking regarding we'll discuss something regarding all molecules in a webinar. And I was searching the name, and I found one very amazing personality when I was discussing with my so many colleagues, friends, and so many colleagues, they mentioned only one name on letrozole. That is Dr. Sachin Dalal. And I was really happy, and I just immediately called up him. So he's an obstetrician gynecologist, IVF specialist. He's a pro trader, Madhu Hospital, Mumbai, Fortis Hospital, Mumbai, Embryon IVF, Mumbai, Sri IVF Center, Mumbai, and winners of various Emojius awards. So welcome, Dr. Sachin Dalal. All are very much eager to listen you.
Thank you, madam. Thank you so much for that kind introduction. Yes, I think I've been now unanimously associated with the molecule letrozole. At the outset, let me thank Dr. Sushma madam, IFS Punjab, IFS Vidarbha chapter, and Nagpur Obs and Gynec Society for having me here on this fantastic platform. Just give me a moment. Yes. So is the slide seen?
Yes, yes.
Okay,
We
madam.
can
Yeah. So today what I'm going to talk about is letrozole, which is a molecule which everybody uses. This is the regular oocyte developmental cycle ovulation that happens. If this everything is in order, it is in sync, patient will get regular periods, everybody is happy, she's got a high chance of pregnancy. But what it actually happens in women with N ovulation in PCO women, that there is supraphysiologic synthesis of estrogen, which gives a strong negative feedback to the hypothalamus and pituitary. This reduces the GnRH production. There is a positive feedback on LH. Due to that, there is low FSH, low LH, thereby there is N ovulation. Now, that is where our aromatase inhibitor enzyme letrozole comes in. It inhibits the synthesis of estradiol or estrone from testosterone. Thereby, the negative feedback is reduced. The pituitary senses that there is no estrogen in the system. It stimulates FSH and LH, which will act on the level of the ovary, and follicular development will start. So, coming to the clinical applications, how many of you are even aware that this simple molecule can be used for ovulation induction, endometrial preparation for frozen embryo transfers, endometriosis and adenomyosis, medical management of ectopic pregnancy, medical management of arteriovenous malformation, that is AVMs, and last but not the least, in cancer of the endometrium, ovary, and long-term treatment of CA breast. This is the normal protocol that we are all aware about. The woman will get the periods. She comes to us on day 2, day 3 of the periods. We start letrozole from third day, give it for 5 days. If she's a normally ovulating woman, you do follicular studies. On day 12, 13, 14, the follicular trigger criteria of 17 to 18 millimeters good endometrium is met. We give an HCG trigger and give 2 options depending upon the case scenario. Either we do an IUI or ask the couple to do a timed intercourse. So this is the normal protocol that everybody follows. Here we start with letrozole 2.5 in the first cycle. If there is no response, then we go to letrozole 5 milligram. So during the lockdown, we came across, and before lockdown, we came across a large cohort of women who were PCO women, clomiphene resistant, and not only that, they were also resistant to the normal letrozole protocol that is given for 5 days. So when I did research, I realized that these women have a higher FSH threshold, thereby they need a higher dosage of the stimulating hormone or a tablet, that is either clomiphene or letrozole or gonadotropin, to bring about ovulation. So in these women, what I usually do is give a 2 to 3 months of pre-treatment with metformin or a combination of metformin with myocytol and dechirorenicetol, and sometimes both. We start off with letrozole 2.5 milligram OD, usually given at night from day 3 of the cycle, and I continue it till the time the lead follicle crosses 16 millimeters. Only if there is no response with 2.5 milligrams, or there is the weight of the woman is more than 60 kilos, then we increase it to 5 milligram or start with 5 milligram, and 7.5 milligram when there is no response to 5 milligram. A few points: start from day 3 instead of day 2 because that will prevent the shortening of the follicular phase. Cancel the cycle if you are doing an IUI if more than 4 follicles of 14 to 15 millimeters are recruited, thereby to prevent having OHSS. Just today, a colleague called me saying that she had given CC plus HMG to a patient, to a resistant patient, and for some particular reason, the patient was lost to follow up. She did not even come for follicular studies. Today, the patient comes 7 to 8 days after spontaneous rupture of the follicles. The ovaries are shrunken, but there is a lot of fluid in the abdominal cavity. So what has to do? She's not done IUI, just CC plus HMG was given and patient was lost to follow up. So in order to prevent such a scenario, if you have follicles more than 4, please cancel the cycle. Trigger is always HCG 10,000 or recombinant HCG, and in a few patients dual trigger, wherein we use HCG, either recombinant or regular urinary HCG plus lupride 1 or 2 ml. Luteal phase support is with dydrogesterone 10 milligram twice a day, or micronized vaginal progesterone. I use the sustained release formulation 200 milligram twice a day for 15 days. Why do we need to give progesterone? Because progesterone modulates the effects of the T helper 1 and T helper 2 cytokines. It suppresses the T cell reactions, inhibits the natural killer cells, and exerts a synergistic action with prostaglandin E2. Thereby, this all prevents maternal rejection of the trophoblast. Also, it supports the endometrial growth for successful implantation. It is a nice uterine contraction suppressing medication. And not only that, it also modulates the immune response to prevent the rejection of the embryo. This is the first paper where Badavi mentioned about extended letrozole therapy. So what he did, from day 1 to day 10, he gave women 2.5 milligram of letrozole per day, and in the second half, there were women who were given 5 milligram of letrozole for 5 days. So short letrozole arm, 5 milligram for 5 days, that is 25 milligrams. Long letrozole arm, 2.5 milligram daily for 10 days. Again, the same dosage. However, what they found that in the long letrozole protocol, ovulation was higher, total number of follicles were endometrial thickness was slightly lower. However, if you look at the pregnancy rates were significantly higher with similar miscarriage rates per patient. Then there was this nice Russian study where they studied the stair-step protocol. What they did from third day of the periods, they gave letrozole for 5 days, 2.5 milligrams. After 7 days, they evaluated the patient. If there was no follicular recruitment, they increased the dosage to 5 milligram. Similarly, evaluated again after 7 days. If no follicular recruitment, again they increase it to 7.5 milligram. And if there was no follicles beyond that for 7 days also, then they cancelled the cycle. In the second arm, what they did, they gave letrozole for 5 days, checked on day 14. If no follicles, from day 21 gave progesterone, and next cycle they started with 5 milligram of letrozole. So here there was a stair-step increase in letrozole. Here it was a single dose. What they found that in group 1, that is the stair-step women, the ovulation rates were higher, pregnancy rates were higher, and significantly the live birth rates were much higher. So thereby, if you have a patient where you given 2.5 milligrams of letrozole for 5 days, after 7 days there is no response, you might want to increase the dose to 5 milligram and can follow with this protocol, thereby hoping to get ovulation and pregnancy rates. Then there was this another study which had the step-up protocol. First cycle, they gave letrozole 2.5 milligram daily from day 3 to day 7. If there was no response, they increased it to 5 milligram. Similarly, if there was no response, they increased it to 7.5 milligram. They found that in the first cycle, 2.5, second cycle 5, third cycle 7.5, ovulation rates were higher and pregnancy rates were also higher. This does not mean that you straight away start with 7.5 milligram. Always start with 2.5 milligram or 5 milligram as I have initially shared with you, so as to prevent the endometrium from going out of sync in this particular subset of women. There were a few studies where they have used letrozole for ART cycles. There was this nice study where they gave corforotropin alpha. This is not available in our country. So this is a single shot rec FSH which is given on day 2 or day 3. Its action lasts for 7 days. Along with that, they gave 5 days of letrozole. They found that the follicular development was higher, oocytes retrieved were higher, and consequently more embryos were obtained in this corforotropin alpha with the 5 days of letrozole. Also, there was another study where they gave poor responders co-treatment with letrozole during ovarian stimulation for IVF. They found that these women might get benefited. However, letrozole for normal and high responders requires further investigation. I personally like to use clomiphene citrate for all patients of poor response, thereby getting a better follicular recruitment, a higher response to the stimulation compared with letrozole with gonadotropins. So you have a patient with poor responder, you might want to use clomiphene citrate instead of letrozole for these subset of patients. Now, there was a lot of study regarding the natural cycle FET, modified natural cycle FET, stimulated cycle FET, and the standard HRT FET. The studies found that when we are doing a HRT FET, the chances of PIH and IUGR is significantly higher in this subset of women due to the lack of corpus luteum, and thereby having more of maternal and fetal comorbidities. So I, after doing a lot of reading, have devised a simple protocol of letrozole for FET. It is for ovulatory and anovulatory PCO women. This for me is the first protocol of choice. From day 2, day 3, we scan the patient, start letrozole 2.5 milligram or 5 milligram OD, and I continue it again till the follicle reaches 16 millimeters. Why 16 millimeters? Because we found that in a few women, if we stop it before that, the follicular growth either lags or it does not grow at all. It goes into a regression, thereby confusing us and having a possibility of cancelling the cycle. After 16 millimeters, there is no need to do that because the follicular will gather its own steam and the growth will occur. Once the ET is 7 to 8 millimeters, I prefer 8 millimeters. A lot of studies are doing with 7 millimeters. We trigger with HCG 10,000 or recombinant HCG at night. After 36 hours, without confirming ovulation, patient is started on progesterone. My choice of progesterone is dydrogesterone 10 milligram TDS with micronized vaginal progesterone 400 milligrams twice a day. If it's an obese lady, I would want to give it thrice a day. Progesterone is given for 3 days for day 3 transfers, given for 5 days for day 5 transfers, and FET is done on day 4 for day 3 transfers and day 6 on day 5 transfers. So simply, you have a cleavage cell embryo, 3 days of progesterone, 4th day transfer. You have a blastocyst, 5 days progesterone, 6th day transfer. Most importantly, two things to be noted. Progesterone, we start off without confirming ovulation. And secondly, there is absolutely no need to give estrogen separately, either before or during progesterone phase or after the FET cycle. FET is done. Review of literature. There are a lot of studies. I've just got the salient points in these. Letrozole endometrial preparation improved the live birth rates compared to natural cycle. Initially, I used to do natural cycle, but it involves a lot of monitoring, a lot of hassle, a lot of blood work. So we've completely stopped natural cycle and gone to letrozole cycle. Stimulated cycles with letrozole present a relatively large advantage compared to HRT cycle and natural cycle with higher live birth. So this guy said that stimulated cycles give a higher live birth rate compared to both HRT and natural cycles. Letrozole clinical outcomes were improved compared with programmed FET cycles. Ovarian stimulation protocol as an endometrial preparation regimen prior to FET might be superior to the HRT protocol with significantly higher rate of live birth, lower risk of miscarriages, preterm births, preeclampsias, and IUGRs. Our study showed stimulated protocol is better than the HRT regimen in endometrial preparation for women with PCOS. So first is fertility, that is done. Now coming to the second usage, that is endometriosis and adenomyosis. We've all had patients who are coming to the OPD with severe dysmenorrhea, severe dyspareunia, and clinically diagnosed endometriosis or adenomyosis. As we all know, endometriosis is an estrogen-dependent chronic inflammatory disease affecting almost 5 to 10% of the women in the reproductive age group. Molecular studies have revealed the presence of aromatase P450 enzyme, which is the key enzyme in the biosynthesis of ovarian estradiol inside the endometrial tissue. Hence, this is the logic for using letrozole in treating endometriosis and adenomyosis. Look at the literature. There were multiple studies. I've got some salient studies here. These guys say that letrozole is capable to treat DIE involving the rectum and the urinary tract. So if you have a woman who has already been operated once, she has a recurrence, or a woman who's not wanting to undergo a surgery, or a young woman before marriage who is not wanting surgery because she is yet unmarried, we might try letrozole to treat deep infiltrating endometriosis involving rectum and the urinary tract. Another study found letrozole combined with dydrogesterone effectively decreases the levels of VEGF, CA125, estrogen, progesterone, IL-6, and TNF-alpha. And lastly, letrozole was as efficient as GnRH analogs to relieve dysmenorrhea and dyspareunia, but not for chronic pelvic pain. Reduction of uterine volume was seen with aromatase inhibitors, GnRH analog, and LNG-IUD. Endometriosis for ART. So you have a patient who's having endometriosis, she is for ART. So there were a few studies of note. The first guys, they found that gonadotropin dosage and estradiol levels on the trigger day were significantly reduced in the letrozole group with no differences in biochemical or clinical pregnancy rate. Another study found clinical pregnancy rate and live birth rate improved after pre-treatment with letrozole added to GnRH agonist treatment versus a plain GnRH agonist alone. So you have a patient with endometriosis whom you've operated, or she's having adenomyosis whom you've not operated. So rather than giving our long agonist protocol or the ultra long agonist protocol where we give a depot of agonist 2 to 3 months before doing a frozen embryo transfer, we might want to add letrozole along with that, thereby improving the clinical pregnancy rates and the live birth rates. And lastly, combination of Lupride depot monthly for 60 days combined with daily letrozole has better clinical outcomes at IVF in women with endometriosis than depot alone. So maybe if you have a woman with endometriosis for ART, you might want to consider letrozole in this particular subset of women. Then there was this fantastic 2020 study came down during the peak of COVID, which I read when there was hardly any clinical work, where there's this fantastic guy, Mitwali, who used letrozole for treatment of ectopic pregnancy. He studied two arms. The first arm were given standard methotrexate injection, 50 milligrams per square meter body surface area. And the second group got letrozole 5 milligrams. They don't have 5 milligram tablets. So they gave 2.5 milligram cut 2 tablets daily for 10 days. He found that there was complete resolution of ectopic pregnancy in same number of patients. However, methotrexate was associated with statistically significant higher liver enzymes, lower platelet counts, and more importantly, the decline in beta HCG levels was faster with letrozole compared to methotrexate. And for us fertility consultants, another important point of note is that 3 months after the completion of the treatment, AMH levels were lower in methotrexate group when compared with letrozole and in the surgery group. There was second study, which is a fresh study from October 2022. There he divided women into three groups. First group was the women who underwent salpingectomy. Second, women who got letrozole 5 milligram daily for 10 days. And third set of women who got letrozole 10 milligram daily for 10 days. He found that 10 milligram daily results in a higher successful rate without any severe side effects. So my clinical utilization of letrozole, I have used successfully in two patients, one of scar ectopic pregnancy and second of cornule or angular ectopic pregnancy. Both these patients, the beta HCG levels were less than 5,000, which is a must criteria. The beta HCG level should be less than 5,000. There should be absolutely no hemoperitoneum. Patient should be hemodynamically stable, and there should be ideally no cardiac activity noted in the pregnancy. This will increase the chances of resolution of ectopic pregnancy with letrozole. So the scar ectopic pregnancy, after giving letrozole 5 milligram for 10 days, the bleeding virtually stopped. She passed a clot and everything was fine. The angular ectopic pregnancy patient, the patient pregnancy after almost 15 days, the pregnancy size reduced. The GSAC got deformed. It came into the endometrial cavity. We did a simple DNC and patient avoided a surgery for an angular ectopic pregnancy. So this I have shared in all the groups. I had also shared my paper of the same. So maybe you have a patient of an ectopic pregnancy, the criteria I have just shared. You might want to try letrozole in this particular subset of patients with your own discretion. This was a fantastic indication. In my 20 years of practice, I never encountered a single patient of arteriovenous malformation. When the first time I got a patient, I thought, let me check whether there is any medical management available. I will be sharing a slide for that. So I found this paper published in 2019 where they had 20 women treated with a GnRH agonist concomitantly with letrozole and tranexamic acid. Tranexamic acid was just given initially to tide over the active bleeding time of the woman. They noted all 20 AVMs resolved within 1 to 3 months of treatment. Of them, 16 women who attempted pregnancy, all including 2 who had uterine artery embolization, one after a hysteroscopic septoplasty, conceived spontaneously with 18 live births. Thereby, the advantage is that it does not reduce the fertility, it is absolutely non-invasive. So I'm sharing my personal experience with you. I had 3 patients. First time, all these patients, 2 patients came one day after another, and the third patient came after 15 days. All 3 patients had bleeding PV. Sonography revealed confirmed arteriovenous malformation on Doppler, which I got it confirmed with a radiologist. All complained of bleeding PV post medical termination of pregnancy. 2 of them had been given kits. One I had given, one had taken from another doctor, and one patient was our post DNC patient. All 3 women were given the options which were there. First, bilateral internal iliac artery ligation laparoscopically. Second was uterine artery embolization. And third was medical management. I had explained to them that this medical management is an experimental therapy. There is only one paper. In case of non-response or non-favorable response to treatment, we might have to convert to either of these 2 options. All the 3 women opted for medical management. So what we gave was Lupride Depot 3.75 grams stat dose and Letrozole 5 milligram OD for 15 days. I gave them a combination of tranexamic acid with ethamsulate for symptomatic relief of bleeding. Mefenamic acid was given for the woman who had pain, and patients were followed up on weekly basis. We had also taken their phone numbers. They were told anytime they have a problem, they're supposed to report immediately. And my staff used to call them every 3 days for the first 15 days. This was done on OPD basis. Patients should not be admitted. There is no need for admission for doing a medical management for arteriovenous malformation. And what we found that all the 3 women had complete resolution of AVM in 2 to 3 months of treatment. So this is a video of the same that I would share. This was AVM that was documented. AVM, you see, the vascularity will go right up to the outer layer of the myometrium, because a lot of times there is a confusion in the mind of our colleagues that is this AVM or is this not. So one thing to be noted is that whenever you have a patient of AVM, just a moment, yeah, whenever you are having a patient of AVM, you should see this particular thing. I will go again. Yes. See the vascularity, it goes right up to the outer border. While in a case of retained products, you will find it only limited to the endometrial or maybe a slight myometrial invasion. Here it goes right up to the myometrial outer border. This is one of the signs that you have to suspect that this woman might be having arteriovenous malformation. So this was of a patient before treatment, and this was after 1 month of treatment. As you can see, there was a significant reduction in vascularity. Bleeding had stopped in 15 days times, and of the 3 women, all 3 of them in 2 to 3 months time, they resumed their normal regular menstruation. Last but not the least, letrozole in cancers. Everolimus plus letrozole results in a high clinical benefit rate and confirmed objective response in patients with recurrent endometrial carcinoma. There was another paper which studied that role of letrozole in ovarian cancer in both primary and recurrent setting. They found that letrozole, which has a favorable toxicity profile, seems to assure a prolonged recurrence-free interval, particularly when used as maintenance treatment in low-grade serous ovarian cancer. And in recurrent cases, it has also led to a prolonged disease control. And last but not the least, we know that letrozole has been used since long in ER-positive CA breast patients. Thank you so much. I stop my share, and that is all that I have to share on letrozole to this August audience. Thank you.
Amazing, really wonderful. Dr. Neha, you'd like to say?
Yeah.
Yes.
Hello, Dr. Daral. It was a wonderful presentation. And I think no one must have talked so much about the letrozole with respect to ectopic pregnancies and AV malformation. That was really a very excellent insight for all the clinicians to practice very safely. Dr. Dalla, I just wanted to have 2 or 3 queries. First of all, when you are using the letrozole, what is your experience about the endometrial thickness? Many of the times we do find that endometrial thickness is not adequate. So do you wait for the endometrial thickness to improve, or do you like to add some supportive treatment for the endometrium?
Fantastic question. This is a question which is asked on the groups or by colleagues almost every alternate day. See, what happens, we have to understand that in a natural cycle or in a ovulating patient, the growing follicle is going to produce intrinsic estrogen, which is going to act on the endometrium, thereby causing a growth of the endometrium. You have a patient whom you've given letrozole, or for that matter, clomiphene citrate for 5 days. You see her on day 8, day 9, standard, right? And you see that the follicle is only 12, 13, or 14 millimeters. At that time, lining 4 to 5 millimeters ही होने वाला है. It has not yet grown, right? So you have to wait for the follicle to grow, for the lining to increase, because still there is a disturbance behind. Can somebody
Hello?
please?
Hello, please, can you please mute yourself?
पूरा cases just
Hello?
Dr.
Hello?
Mandeep Kaur,
The patients come back.
Hello, please. Discussion is going on. Please mute yourself.
yeah, and somebody started the whiteboard. Ask this person to share, stop the whiteboard. Yeah, that's better. Fine. So you have to basically wait for the follicle to cross 16 millimeters. Dr. Mandeep, can you just wait right now? We are still having this discussion. We can start it in some time.
Dr. Mandeep. Dr. Mandeep,
Can you stop the screen share as of
can
now?
you please, Dr. Mandeep, we can finish the discussion first. Dr. Mandeep,
Mandeep ma'am, can you please stop sharing your
stop
screen?
sharing. We'll have this complete this discussion. First talk discussion.
Ma'am, you're muted.
I think the
All you
pharmaceutical
need to do
company
is
has
just
Dr.
press the
Mandeep,
button
Dr.
stop
Mandeep,
share.
Dr. Mandeep, please stop sharing your screen. We are discussing about the first talk. Dr. Mandeep,
I think
please.
she's not able to do it. Mandeep ma'am, on the
Maybe,
top.
maybe the admin,
anyone-
maybe the admin or the host needs to do that.
Yeah. I think the
Yeah.
pharmaceutical
Actually,
company has that. Yeah.
I was trying for the same only.
Yeah.
I've done
It's
it.
okay. Please, Dr.
Yeah,
Sachin,
yeah,
please
right.
continue.
Yeah, so you have to basically wait for the follicle to grow, and you will find, classically, follicle is 13, 14, 15 millimeters, endometrium is 5 millimeters. Call this patient after 2 days. Let the follicle grow to 17 or 18 millimeters. You will find endometrium growing to 6 or 7 millimeters. Still, if it has 18 millimeters, your PSV, the vascularity is not too much. You're just seeing some vascularity. This follicle is not yet mature. Call this patient after 1 more day, and you will find the endometrium, which was 6 millimeters, jumping to 7.58 millimeters. So basically, what we practice in obstetrics, watchful expectancy, needs to be done the same with this patient as well.
Yeah.
Only if you don't have a response in the first cycle, after waiting adequately judicially, then you might need to add estrogen, and that is in less than 2% of the patients. Otherwise, in majority of our patients, be it for planned intercourse, be it for IUI, be it for FET, I hardly ever use estradiol. And especially during COVID, post-COVID vaccination, I am scared of using estrogen because, just today somebody has asked on one of the groups that a 26-year-old girl, PCO, that doctor has given her E2 of 12 milligrams a day.
Mhm.
All sorts of masala, what we call adjuvant, but lining is not developed. So I've just told switch to extended letrozole.
Yeah.
Start with 2.5 milligram. Why do you want to subject a young 26-year-old PCO girl to such high doses of estrogen? And what I have found in my clinical practice, that if I have to ever start estrogen, majority of the times I've never had the reason to cross 6 milligrams. If you are having to give more than 6 milligrams, either the tablet is not working well, so change it to estrogen which is available in the gel form or a vaginal estrogen, you will find much better responses.
Yeah. There was one more thing. When you, for the adenomyosis or endometriosis, when you like to start with the letros, you start in the luteal phase or you can start in the proliferative phase. What
I
is the risk
usually
of
start
that?
from day to day 3 of the periods. So, the
Okay, but
periods have come, the endometrium is shrunken, because see, as we understand that endometrium is going to grow with letrozole when you're going for an extended period of time. So I would rather wait for the patient to shed the endometrium and then start with letrozole, always.
yeah, but that is not for the stimulation. If you want to start it for as a treatment of endometriosis, you want to give for 1 month or so, especially you have done a laparoscopy, you find there is endometriosis and you want to put the patient on the letrozole. So you will immediately start from day 7, day 8.
No,
What
so
are the
if
chances there?
it is a surgery patient, then
Yeah.
surgery, after surgery, I would always want to give her a lupride depot, because
Okay.
lupride depot works the best for post-surgery patients. So give lupride depot for 1 or 2 months, and depending upon whether it is stage 3, stage 4 endometriosis, post her for IVF. If
Okay.
it is not for fertility, yes, then you can give lupride depot, and then post surgery, along with your tablets, you can start letrozole. So, see, basically, all laparoscopic surgeries you will be doing on the follicular phase 7, 8, 9, 10,
Yeah.
11,
Yeah.
12 day of the period. So, that is essentially, so rather than starting from the luteal phase, why not wait for a 10 or 15 days more? Let the woman get the periods, let her shed the endometrium, and then start with letrozole.
But what is the risk of developing cyst in this patient? The follicle will start developing on day 2, day
Follicle
3.
is going, follicle development is going to happen, but when you are going to give it for a prolonged period of time, you will find that these follicles either resolve or they don't go beyond particular size.
Okay. And the last question, have you used letrozole for OHSS patient?
Letrozole,
Yeah.
there were a few studies where letrozole they have given for prevention of OHSS. So they did the pickup and then they started letrozole. So
Yeah.
what I do is, when I'm starting a patient for stimulation, I'm very clear at the beginning whether I'm going to do a fresh transfer or whether I'm going to do a freeze-all. So if and only if the patient is a normal responder or the follicles retrieved are less than 15, I might attempt to do a fresh transfer. In
That's
all other women, I'm going to give only a agonist trigger. And in my 10 years of fertility practice till date, trust me, I have not encountered a single patient of OHSS. Though you have a patient, say you have a donor. I'm scared of using the donor word, but yes, you have a donor where you've stimulated her, you've done the pickup, you've given for donor. The ART Act is very clear. You are supposed to give strictly a agonist trigger. There is no role of dual trigger in donors. There is no HCG that should be given to donors. So you've given an agonist trigger, and you are suspecting that despite giving an agonist trigger, this patient might have a secondary OHSS. So ये केस में क्या करना है कि the best thing to do is give cetrorelix 0.25 milligram twice a day for 2 days. And when you see these women after 5 days, trust me, everything will have shrunk off.
But then you never use letrozole for these patients.
Never. I have never had the reason to give letrozole.
Okay, okay. Thank you. Thank you for your great insights.
It was really wonderful discussion.
Yeah.
Thank you
And
so
very
much.
good study about letrozole. Very
Yeah.
small particle. Yeah.
Thank you so much. I hope after listening to today's talk, because after my talk at 2 places, I've got a lot of comments or queries from colleagues where they've started using it in AVMs and in ectopic pregnancies with excellent results. So rather than operating these women, you might want to actually go ahead and save their fertility by giving them letrozole for ectopic or AVMs.
Yes.
Thank you so much for having me here. It was a pleasure.
Yeah.
I hope I did justice to the topic, and see you
Sure.
Yes,
Thank you very much.
sometime.
Thank you.
Thank you.
Thank you, Sachin sir. It was totally eye-opener for all us youngsters who are practicing infertility. There were a lot of points which we would, take into consideration when we are practicing infertility and using letrozole for that matter. Now, coming on to our next talk.
Request chairpersons to invite Dr. Mandeep Kaur, ma'am.
Hello.
Hello.
Yes, ma'am. Dr. Neha.
Yes.
Uh,
No. Dr. Mandeep, you can start with your presentation.
yeah, but her CV,
Yes. CV,
please
where is?
display her CV also. No?
Yeah.
Dr. Neha, are you going to read it?
Yeah, I'll read it. Dr. Mandeep, she is MD, and you have done your reproductive medicine, FNB. She's a director at the Star Super Specialty Hospital. Her topic of interest for research are use of GCSF in patients with RIF, blastocyst culture, laparoscopic ovarian drilling, conservative management of advanced car ectopic, and a single embryo transfers. She has written chapters in various books on the regulation of menstrual cycle oogenesis and folliculogenesis, spermatogenesis, epigenetics in ART, total quality management in ART lab, recurrent implantation failure, instruments used for hysteroscopic surgery, and outcome of children born through ART. I think Dr. Mandeep, you are full of all the knowledge, right from the ART to the lab to the everything. So it's great to have you with us, and I'm hoping for a great discussion ahead. Dr. Mandeep, you can start.
Yeah.
You can share your screen.
Can they just help me with sharing the screen because they blocked my.
You have started the whiteboard actually. Just a second. Corona people, can you just help ma'am share her screen?
Ma'am, she can.
She can.
We don't
Ma'am,
have
can
any.
you just
We don't have any
switch off the
restrictions.
whiteboard first?
No, but my screen is showing that I'm sharing the screen.
We
you
are
see
not
my-
able to see. No, we are not
No.
able to see.
Ma'am, can you
Is it
stop
being
sharing
written?
first and
Can
then
you
again
please,
try to
please
share it?
stop sharing again?
Okay.
Yeah, we
Yeah.
can see it,
Now,
ma'am.
yes.
Yes.
Please go ahead.
Mandeep, ma'am, we can see your screen now.
Thank you. Good evening. So today we are going to discuss the injectables that are used in ovarian stimulation. So I cannot move my slides further.
Just
Yeah.
okay. You
Yes,
we
yes,
can see
moving.
now.
Yeah.
Dr. Mandeep moving, yes.
Yeah. So success in ART is not just the effect of drugs that we are using. It is an effect of multifactorial equation. The patient variables, the obstetric management, of course, the importance of embryologists and the lab cannot be undermined. And drugs, though they have a small important part, we cannot just undermine that also. So it's an effect of multifactorial things. So the first thing that we are going to discuss is gonadotrophins. So because of the presentation, I went through multiple things, and it was very interesting to look at the history of gonadotrophins. And the history of gonadotrophins starts with the presence of chorionic gonadotrophin, in the urine of horse and pig. And from there, they started separating. And then later on, it was found that pituitary FSH can be found in the menopausal females. And then slowly, steadily, they started separating it. And first, we got to get urinary HMG. And then the urinary HMG was refined, the urinary proteins were separated, and then the LH fraction was reduced. And then slowly, purifying mechanisms started developing. And later on, around in 95, they started using the recombinant FSH was formed from the master cell banks. And then slowly recombinant preparations. And then, like he was talking about corifolitropin, the recombinant preparations, which can have an effect with one injection for 7 days, or certain preparations which have higher potency started coming up, the corifolitropin, then the folitropin delta, and so many other preparations started coming up in the market. And it's quite interesting to see. So presently, what we get to do with the gonadotrophins is the research which has happened over almost a century. and we get everything on the plate. We don't need to do much of research, and we just use what we get from the research molecules that has been done by people in the past. And then recombinant LH also was developed, but it came in the name of Luveris, but slowly it went out of use, because not much benefit was found in comparison to the lower cost preparations like the HMG, where we have already got LH in equal quantities. So urinary HMG, which we still use, has equal potency of 75 international units of FSH and 75. And many people believe that it cannot be used in PCO. I think all of us use, and it is more cost effective. And even when the postulations are that the LH-FSH ratio is deranged and they have a large amount of LH, we all know, and we have all used, that HMG can be very well used in PCO patients, and it is quite useful. So then highly purified preparations started coming, and the separations was done with the chromatographic techniques. And slowly, as you can see in the chart, the purity was increased, and the LH activity was reduced. And if one wants to use highly pure FSH, it will have more content of FSH compared to the LH. So the recombinant techniques are also quite interesting if you read the literature as to how they were developed, the cell banks, and the basic intention was the batch to batch variability which was happening in the HMG preparations, which are not found in the recombinant preparations. And a lot of theoretical things came up that, there is a prion scare and they don't have traceability. The urinary preparations don't have traceability, and they don't have batch to batch consistency. And most of the studies for recombinant FSH that we see in literature are most of the times, funded by the pharma companies who come up with recombinant preparations. And I'm like an infertility specialist, and I do stimulations solely with the HMG. Most of the times I hardly use recombinant, and I don't see any difference. But it's not my practice that I should be talking about. If we look at literature also, in terms of the live birth and the pregnancy rate, there is not much difference. However, the only benefit is that recombinant FSH preparations give rise to more number of oocytes and sometimes might get us more embryos for freezing. And if we look at that also, I think if we look at the selection, if we get less number of eggs, maybe we get better quality eggs also. So because I'm an HMG user, I always advocate people and talk of the benefits of HMG over recombinant FSH. I went through a lot of literature. Most of the studies, they say that there is not much difference, except for one thing that I said, that recombinant FSH gives rise to more number of eggs compared to the HMG preparations. And then highly pure preparations now can be used subcutaneously also. And of course, they don't give us many fancy self-administration devices, but one can do easily without that. Then the newer gonadotrophin preparations, the biosimilars, just like we see Foley graph, and there's a lot of literature on biosimilars also. They have similar chemical structure, but the biosimilars have slightly different way of formation compared to the recombinant FSH preparations. They don't use the recombinant way. They are prepared in a different way, but the chemical structure is the same. Then corifolitropin, which given one injection lasts for a longer period of time. And then folitropin delta, which has a higher sialic acid content. And so if we give 150, its effect is more compared to the routine recombinant FSH preparation. So the role of addition of LH, of course, HMG is the drug of choice in hypogonadotrophic hypogonadism, because they don't have any inbuilt FSH and LH. So hypogonadotrophic HMG has to be used. If we use recombinant FSH in hypo patients, probably we will land up in a mess. We will not have good number of eggs, and probably they might not respond. And why I advocate HMG usage, another point is that if we use FSH preparations, sometimes we see in the middle of the stimulation that there is a stagnant response. And we sometimes need to add LH if we have suppressed too much in those patients. But in HMG preparations, we don't see stagnation in the middle of the cycle, especially when we start the antagonist. And poor responders and advanced age, most of the category of patients that we get in our practice are these kind of patients. So there also HMG preparations really work. And of course, it is not the time of mass treatment. We need to do individualized ovarian stimulation, and depending on the patient's needs, sometimes people, pad likh ke, when they come, they ask for recombinant preparations. Of course, we can give them, but protocols should be crisp and individualized to the requirement of the patient. So in males, hypogonadotrophic hypogonadism concomitant with HCG is the indication for gonadotrophins, and in women, women who are unresponsive to CC, and in hypo patients and in IVF stimulation. So contraindications are ovarian cysts, abnormal uterine bleeding, breast cancer, and failure patients. Testicular or ovarian failure patients, unnecessarily giving them HMG and recombinant preparations would not be of much benefit. Most of the times they come back with headache, abdominal cramps, bloating. I don't think I need to mention, everybody knows this. Then coming back to GnRH analogs, GnRH analogs are the peptide versions of the GnRH that is present even in our body. So the embryology starts from the olfactory placode. So from the olfactory placode, the GnRH cells originate, and during embryogenesis, they migrate to the arcuate nucleus of the hypothalamus. And in our body, the GnRH production is pulsatile, and that is how, with the GnRH pulsatile production, the FSH and LH production happens. So when we talk of the agonist, the pharmacology of agonist, the agonist and antagonist both are analogs. They are peptide forms which are similar to the GnRH that is present in the body, but this GnRH that is present in our body has a very short half-life of 1.5 to 2 minutes. It gets out of the body very fast, whereas the agonist and antagonist are there to last depending on the dosage that we give. So how does the agonist act? The agonist first causes a flare response. So it causes the FSH and LH production to a large extent, and then it depletes the receptors of the FSH and LH content, and then there is a continued suppression after the action of the GnRH agonist. And antagonist works in a different way. It is a competitive blocker, and its half-life also is its effect goes after 24 hours, which we talk in the drawbacks of antagonist, that after 24 hours its effect goes. That is why we need to use it, but it's a competitive blocker. But because it is a competitive blocker, its effects goes away. It leaves the receptor for our agonist trigger to act. So agonist trigger can work in an antagonist protocol only because it causes the competitive blockade of the receptor and leaves the receptor for the agonist to act as a trigger. So this is about the pharmacology. And this again shows the mechanism of action. So first a flare, and then a continuous, the receptors cannot come out. They are basically internalized and they are destroyed. Whereas in antagonist, this is not the case. The receptors, they remain. The antagonist just gets washed off. So this is how, so the flare response, and then the exhaustion of the receptors, and then finally the internalization. So most of the preparations are available in the market. I have not used intranasal preparations. I don't have that experience of using the intranasal preparations, but of course we all use the long-acting intramuscular or and the short-acting, the subcutaneous version of leupride, and then the triptoderin decapeptyl, which we use as a trigger for agonist trigger. So then the clinical applications, of course, most of the times people have replaced the antagonist protocol for the ultra long protocol that we used to do for endometriosis. Many people are still doing long agonist protocol for endometriosis, but I prefer doing antagonist protocol in patients of endometriosis also. But yes, long protocol can be done. And then to prevent premature LH surge, like for the agonist, And then as a trigger, and a lot of literature is coming up for luteal phase support. Agonist shots are given and prevention of OHSS. Then cetrorelix and ganirelix. Cetrorelix is available in 0.25 and 3 milligram. I don't use 3 milligram, but 0.25 we all use. And ganirelix is slightly costlier, but it can be used in patients who have severe allergic reaction with cetrotype. And single dose, multiple dose, or flexible and fixed, that are the protocols that are used for antagonists. Antagonist protocol, a lot of things are coming up, whether we need to do estrogen pre-treatment or not, oral contraceptive pre-treatment or not. Then a lot of, if we see a cyst, then we can give antagonist for some time. The sandwich protocol. So antagonist protocol also has multiple ways and forms in which it can be used, and it is most patient friendly. Most of the people have replaced their practice with the antagonist protocol because I think the biggest boon of 21st century is because when in 2011 and 12, we used to do IVF stimulations categorically, like he said, in donors. We used to see every day donors coming back with OHSS, and we used to make them walk in the ward and used to remove fluid from there. So the biggest, I think, development of 21st century is the development of the agonist trigger and the GnRH antagonist. And we take it so lightly because we are doing it left and right, but this is something which scientific advancements has given us, and we are all able to develop an OHSS free clinic where we hardly see any patient of OHSS. This is just because so many researchers have, found out that this agonist can act, because when we were using agonist, we could not use a trigger other than an HCG because there were no receptors to act on. And now when we have an antagonist, and agonist trigger is something which is a boon. And if we've seen a lot of OHSS patients in our practice before, I feel great when we give agonist trigger and the ovary just shrinks to its normal size by the time the patient gets their periods. So then there are various GnRH agonist regimens also. Microflare is coming up in a very beautiful form now. It is becoming in poor responders, many people are talking of, and a lot of papers are coming up on microflare protocols. Probably it is the method of choice now in poor responders. Compared to the antagonist protocol. Why we do antagonist protocol for poor responders is because we now know the knack of it, and we find it very easy. But long protocol was once done. Long protocol, we cannot deny it's sometimes we get stuck in antagonist protocol. Sometimes we find empty follicle syndrome, or sometimes we get premature LH surge. They are the ones. So just we cannot leave agonist protocol and its importance. It's a very flexible protocol. And in agonist protocol, the synchronicity of the follicles is very beautiful. Just like when we see asynchronicity, of course, you can do estrogen pre-treatment. But when we see asynchronicity in the antagonist protocol, then it reminds us of the agonist protocol, where we get a very beautiful synchronous cohort, and then many people can fit very nicely in the batch because you can delay it in antagonist protocol. Sometimes you cannot even avoid a Sunday, because if you avoid a Sunday, the progesterone rises, and it does not give you that much of space. Whereas an agonist protocol is very beautiful in that sense. 2-4 din, 2 din aage piche, it does not really matter. And then there is a short protocol and ultra short protocol, which we used to do earlier, stopped doing because of the antagonist protocol. But then we should know, because sometimes, we might get a patient where we might need to do these protocols because of certain reasons. So short protocol where we give agonist for 3 days and then we stop it. Sometimes you can do this and sandwich antagonist also simultaneously later. This is done in the beginning to synchronize the follicle or manage the cyst. And then later on, you can convert it into an antagonist protocol also later on. Then the ultra short protocol. So I don't need to say much about but everybody has their different practice. We usually do flexible antagonist protocol in our clinic. So we look at the, so I'm not doing many hormones. I don't do a baseline hormone or baseline scan is enough. So if there's no cyst, the endometrium has well shed, and I don't do baseline hormones. But many people still believe, so you can do a P4 if you want to. And if there is a asynchronicity, I would like to manage it and then only start, because otherwise the P4 will rise and then we might have to unnecessarily freeze all. Then when I see a follicle of 12 to 14 millimeter, I start my antagonist daily. And then 17 millimeters, 3 follicles, I give trigger. So if the number of follicles is more than 15, sometimes 16, 17 also, but patient should be asymptomatic. She should not say that I'm having pain in my abdomen, so we give HCG trigger. But if it is more than 17, or patient is symptomatic even at 15, we get scared of OHSS and then we give agonist trigger. And then usually earlier I used to give 35 hours trigger, 35 hours trigger, and then a pickup. Now I've had faced a few surges, so now I play safe. It does not matter. Even 34 hours is very safe. Sometimes the donors, where they have repeatedly, now that problem will slowly get solved, but donors where they have repeatedly donated, sometimes even at 35 hours they tend to. And if you are giving agonist trigger, it is always good to play safe at a shorter duration compared to a longer duration. So 34 hours is more safer if we want to prevent 1 or 2 surges that might happen. So 34 hours is something that I do for everything now, because I feel there's no difference in the maturity rate or anything. So 34 hours and then embryo transfer. At day 5, we are following 100% blastocyst formation. If blastocyst is not, if blastocyst is not formed, we cancel the cycle, but we don't do day 2, day 3 transfers in our clinic. So then coming to the trigger, HCG trigger. HCG was actually, if you look at history, HCG was invented even before the pituitary gonadotrophin was found in the menopausal. So HCG was something which was taken as gonadotrophin, which was taken as a stimulating agent before gonadotrophin. So per-gon-di, if you look at the name which is used in literature, was actually for the mare, pregnant mare's HCG, which was used as a stimulating drug in the beginning, and later on it was found out that no, it's not the it's the FSH, the HMG, the urinary HMG, that is the stimulating agent. So of course HCG has its own beauty. It's if you look at the urinary preparation, it is very cheap, and it has a long half-life, and it will do a short job. And of course, the scare of OHSS starts only with the HCG, so one has to be careful. But what is the difference between the agonist triggering and the HCG triggering? So there's a very beautiful article, It Takes Two to Tango. If you look at the agonist triggering, it is more physiological. Just like the LH surge that happens in our body, the agonist triggering is causing the same effect, just like the physiological LH surge. So when the HCG agonist trigger, so I remember this was the time when this 2011 article came, we started looking at the agonist trigger and started using it in our practice. And that was the time when we stopped seeing OHSS in our clinics. Sometime later, maybe it takes a year or so to, bring things that we see in the articles in the European and the American literature and bring those things into our practice. But that was the time when this thing really happened, and it is fascinating. So of course, the FSH and LH surge combined together is something that helps us in patients whom we have faced with the empty follicle syndrome with a single trigger. So there is a role of a dual trigger or the agonist trigger in patients who have had a history of empty follicle syndrome. Another thing is that this is a very beautiful article where a male and a female. So this is the representative of the FSH and the LH surge, And the combined surge is something which makes it very closer to the. So of course, donor, I think the time of practice is now very serious with the ART law coming up, and things becoming more into the common man's, because when a law is formed, a common man reads and they can challenge you in certain things. So if one develops OHSS, the early onset OHSS, they can sue us in the court of law. So here comes the role of giving agonist trigger and not giving HCG trigger in donors, even if they land up with empty follicle syndrome, no problem, but never give HCG trigger to a donor. And they come back to normal immediately, and it reduces the treatment burden on the donor. Then in fertility preservation patients where we need to subject them to chemotherapy, no HCG, no OHSS. And then patients with empty follicle syndrome, we can always try. And another thing is that after, like in the previous times when we used to give HCG trigger, we used to start picking the eggs, and then we in the follicular fluid, they used to say empty, empty. Then we used to do a kit test, the urine test for pregnancy, to see if she has taken the trigger properly or not. But now for the agonist trigger, that UPT kit is not going to work. What is going to work is their serum progesterone levels or their serum FSH, the serum LH levels, which are going to work. So LH predictor kit might help if we really want to find out in our OT what is happening. And of course, it has physiological advantage. So trigger dose, many people still give leupride acetate 1 milligram, 2 milligram can be used. It is more cost effective. But as a policy, we use the decapeptyl in the dose of 0.2 milligram. And of course, both can be used. The only problem with leupride is that it is a multi-dose vial, and then we become concerned over whether the proper amount of dosage has been picked and injected or not. So the beauty of triptorelin is it comes in a very beautiful pre-filled device, and then less of problem. So what are the troubleshooting things in the agonist trigger? So how can we troubleshoot if we land up in a problem? First thing is that it's always good to use a higher dose. Not many dose finding studies, but it is always good to use 0.2 milligram instead of 0.1 milligram. It is always not wise to use it from a multi-dose vial, because we are worried. And then of course avoid avoid antagonist very close to the, because as we said that antagonist is acting on the competitive blocker of the same receptor on which our agonist is going to act. So avoid giving antagonist at least from 12 hours from the agonist trigger. So for example, the antagonist during day, and then the agonist trigger in the night would be a very good thing to do. But if you want to program it according to the batches, at least keep a distance of 11 to 12 hours between, because the antagonist is going to move away from the same receptor where we are going to. And then it is not good to give too much HMG on the after we have given it, after we have given the trigger. And the problem comes in patients where the central system, like PCO patients, their central receptors, if they are classic PCO and if they have too much symptoms, sometimes the agonist trigger does not work because they have a hypothalamic dysfunction. So, and in obese patients, it is always good to use a higher dose. Thank you very much.
Dr. Manjeet, it was an excellent presentation. I think you have covered everything. Starting from all gonadotrophies, the older and the newer this thing, also all GNRS analogs in a very fantastic and very, in a different way you have mentioned in the practical aspect also you have covered. And I think you are a HMG lover.
Yeah.
So
yes, Dr. Mandeep, it was really a Herculean task to cover up so much of the things.
Really. And there is always tussle between, the HMG lovers and recombinant lovers. So
yeah,
I think there are many studies, they also proved that the results are considering the pregnancy and the take-home baby rate, these are the equal, I think so. So sometimes there can be, if you are HMG and you are not getting this, so after HMG next, that can be the your this thing. So you are, whether you are using after HMG, you are not getting pregnancy, you are using recombinant FSH, then
No, not really. If after using HMG, because see, what we are doing in our clinic is we are doing 100% blastocyst culture. So most of the times it is something else. The quality of eggs might be the problematic, age might be problematic. So it's not basically the drug. But yes, what I would like to highlight upon this is that the problem with the HMG is that lot of people are supplying HMG. If you look at people who supply HMG, there are so many people. So what you need to do is that you need to find a good. So the problem is not with the product. It's not with HMG. It's with the brand, or it's with the product. If it is good, and if you because we are using only HMG, we immediately find out. We don't keep more than 1 or 2 brands in our pharmacy. So we keep only 1 or 2, and we immediately find out if there is a problem. If the response is not as expected, we cancel it. And since it's cheap, it's we can easily cancel, bear the cost of the drug and change the product immediately. So because we are using only HMG, we have a very strict control on the preparations. And I feel that if one is using HMG, don't keep too many brands in your pharmacy. Then it becomes very confusing. You're not able to find out if there is a quality problem or if there is a cold chain problem. So keep only 2, and keep 2 at the equal pace, and then there is a very good comparison. And then the problem is not with the preparation, the problem is with the cold chain and other brand related problems.
which are your brands? Which are your brands?
So earlier I was using Minodac from Bayer. And I think there's one Dr. Sangeeta in Jaipur, and she and me, we used Minodac for years together. And then the day they withdrew Minodac from the market, we became like, there's no roof on our head like that. So then we started using more preparations. Now, presently, we are using EMA from the Corona Remedies. It is good. And then we are using this Ugon HP. It is from Samarth. And others are also good, I would not say. But sometimes in a particular place, like in your place, you might feel that Humog is also doing a good job because their cold chain is well. And your stockist should also be very well selected. So we don't buy, we've kept our... So cold chain is very important for... And then we never buy liquid preparations, because patients only do a mess with the liquid preparations, because either they will take less dose, more dose. So we take a lyophilized powder form. Even if they keep it in the freezer, it will, even if somebody by mistake, even we tell them, but liquid preparation, once it goes into the freezer and freezes, it's gone. So probably what I feel is that now is the time for us to, look at contemporary things, the olden things than the new, because when Luberis came, I think most of the people started using recombinant LH, and it was so costly. And
very costly.
And in HMG preparations, there is a small amount of chorionic gonadotrophin also, which some amount of HCG is also present in the preparations. It also really helps in endometrial receptivity. So because we take all the embryos to blastocyst, we can find out. But if the follicles are not growing well, then that means HMG is bad. Then we don't take the patient to pick up. We'll just stop there. And we'll not let that IVF happen. We'll stop it.
You can't change it. You are not changing your protocol.
No, but I will use recombinant only. Even in the next cycle, I will use I will not use recombinant. I will use HMG only.
Okay.
Yes.
Thank you very much. It was a good discussion. Okay. Any questions you would like to add?
No, I think she has really done a marvelous job and covering so much of the
covered everything.
Yeah, cover everything. Only thing with the HMG, I think only when you don't have a IVF backup, then you really need to be little careful while using your doses. Do not increase the doses very fast, because if you land up into the multiple follicles, then the problem will arise. So when you have to be very cautious when you are using HMG. That is the only, I think, take-home message for all of us. And rest of the
I
things
think,
I think we have
if you
covered
have
very
an IUI setup, it has to be cautious even if you are using FSH.
Yeah.
So it's
Yeah.
both the same. FSH and HMG responses
It
think-
are
depends, yeah.
almost.
Depends
I
upon
think in
the
that sense,
what type
you
of
should always become friends with one fertility specialist in your neighborhood. The day you create a mess, you just tell them
We are
ki,
going to clean it up.
convert it into
Inside.
IVF and do it at a low cost so that the patient does not fight with you.
Yeah, I know.
So it was an excellent presentation, Mandeep ma'am. Now we'll go ahead. Are there any questions?
I think she has cleared everything. Very nice.
Yes, ma'am. We'll go ahead. We'll go. Firstly, I want to thank our chairpersons, Dr. Sushma ma'am and Dr. Neha Lad ma'am.
Yeah, thank you. Thank you for inviting us.
Yeah, it was an excellent chairing session. Thank you so much, ma'am. So we'll move ahead to our next session. It's panel discussion.
Before that, Neha, I think we'll take the quiz.
Yes.
But before panel discussion, even I want to know who are the panelists available now.
Yes, ma'am. We'll share the screen.
Okay.
Just a few moments.
So here we are with that exciting quiz, and myself and Neha would be the quiz masters for today. So coming on to our first question. First, let me just brief you people how you're supposed to be answering these questions. Please message to the Corona group which is there and write the question number and then leave a space and write your option and also your name and from which society are you. That would be great. The winners would be announced at the end of this session and you will be getting definitely wonderful gifts from Corona people. So coming on to our first question. That is, according to the ESHRE consensus on the definition of POR, according to the Bologna criteria, which of the following is incorrect? The first one being advanced maternal age, that is more than 45 years or any other risk factor. Number 2, a previous poor ovarian response, that is cycles cancelled or less than equal to 3 oocytes with a conventional protocol. Number 3, an abnormal ovarian reserve test, antral follicle count less than 5 to 7 follicles, or AMH less than 0.5 to 1.1 nanogram per ml. And the last one, in the absence of advanced maternal age or abnormal ORT, 2 previous episodes of poor ovarian response after maximal stimulation are sufficient to define a patient as a poor responder. So we have around 10 seconds for this question. Unfortunately, the timer is not working, so I have it here with me. So we are starting the time now. Again, I'm repeating according to the ESHRE consensus, according to the Bologna criteria, what is the definition of POR? The options are right there in front of you. So please write the question number, then the option, and your name and from which society do you belong. Time up. The answer to this question is the first option because the advanced maternal age, which this consensus takes as, is more than 40 years of age. Coming to our second question. Letrozole was discovered by option number 1, Siba Gigi AG. Number 2, Frank Pelopi. Number 3, Askim. Or number 4, Zondek.
Please don't refer to Google.
So the time has started. We're giving you 10 to 15 seconds every question. Repeating the question, letrozole was discovered by Siba Gigi, Frank Pelopi, Askim, or Zondek. The time is up. The answer is Siba Gigi. Option number 1. Neha, would you like to take the third question?
Yes, so the next question is gonadotropins are released from which area of hypothalamus? So the first option is paraventricular nucleus. Second option is medial mammillary nucleus. Third option is arcuate nucleus and preoptic area. And fourth question option is ventromedial nucleus. And your time starts now.
Time when everyone is writing.
You can write question number and the option, whichever you feel is correct near it. We are getting a lot of response. Okay, time is up. We'll move to next question now.
Aneha, you have to give them the answer also.
Yes, okay. The answer is arcuate nucleus and preoptic area. Gonadotropins are released from this area only, arcuate nucleus and preoptic area. Okay, moving to the next question, which is not correct about the two isomers of clomiphene. The first option is N-clomiphene is 62% and zoo-clomiphene is 38% concentration. Second option is N-clomiphene has more anti-estrogenic action. Third option is N-clomiphene is less potent than zoo-clomiphene. And the fourth option is half-life of N-clomiphene is 2.5 to 11.8 hours.
So the time has started.
Fourth. Question number 4 is 4.
We request all the esteemed faculty to have the answers given to us on the chat box and let the listeners answer for themselves.
Yeah, we are getting answers on the group as well.
The time is up. Answer being that N-clomiphene is less potent than zoo-clomiphene. It is more potent.
Okay, so we are moving to the panel discussion now. So first we'll request our chairpersons. Ma'am,
The
Parul ma'am.
moderators for this session.
Our first moderator is Dr. Manjushri Boob ma'am.
We welcome you, ma'am. Ma'am is a renowned infertility specialist. And she is a senior dynamic obstetrician and a gynecologist, infertility and ART specialist, and a laparohysteroscopic surgeon. She has received many awards to her accolades, and she has received Vigyan Vardhan Award from Foxy India. She has bagged many national and international awards for best scientific paper and poster. She is a true academician, and she has a keen academic acumen with zeal and enthusiasm to advance in this field. We welcome you, ma'am.
Thank you so much. Excellent evening to one and all. Please go ahead.
Our next moderator is Dr. Anupama Chopra ma'am. She's a medical director of Embryo IVF Nursing Home and Maternity Hospital. She has 24 years of clinical experience. She has been vice president of IMA Jalandhar. She is the chairperson Jalandhar of Mission Pink Health for 2021 till date. She has done many research work and she has been an executive member of IFS Society. We welcome you, ma'am.
Thank you so much. And let's start with our panel discussion right on. But the panelists, I think everybody will be a part of the panel. We have Dr. Niti with us. We have Dr. Charu with us.
Charu,
yes,
ma'am.
Yes, ma'am.
Oh, Dr. Pranita. Hi. No? Dr. Manisha?
Yes, ma'am. I'm there.
Yeah, it's an attendance going on in the class. So I think everybody can be included, like all those who are attending this webinar. Okay, so I'll be screen sharing and I'm starting with my first. So we are here to break some myths in the fertility practice, and let's see how many we are able to break, how many myths. So regards from Jalandhar, and just hold on, next. So all of us are getting ready to dive into this mesmerizing world of ART and discover the intricate interplays. And already Dr. Mandeep has actually unfolded so many things. So the answers are going to be very, very simple. So the first question to the panelists is, we are here to explore the relationship between FSH hormone dose and follicular response. So the question to the panelists is, does higher dose of FSH gives us better results? So over to the panelists one by one.
No, the higher dose of follicle stimulating hormone does not always give us the more response. We must go through the, I can mention the criterias, or it is depending on the age, the AMH, the AFC, the previous stimulation of the cycle, male partner insight, and then the dose should be selected.
Also the weight, ma'am, BMI.
Okay, Dr. Manisha.
Yeah, ma'am. One thing left, only thing the weight and BMI, because obviously
of course.
Yeah, that is another factor.
Weight and BMI, the most important two factors according to you, Niti.
Most important factor is the age, and only in patient, age of the patient.
Okay. So any other one who wants to answer the question? Contrary to popular belief, higher FSH doses does not necessarily result in a better follicular response. In fact, studies have shown that lower dose can be as effective in stimulating the follicular growth. And why to waste patients' money, and why to waste, or why to give the symptoms of follicle stimulating hormone? So there is a case, a 27-year-old patient married from last 8 years. She is a known case of hypothyroidism controlled on thyroxine. There is male factor infertility. The 7 million count and 30% sluggish motile sperms are there. Her AMH is 1.5, FSH 7.37, NH 4.01, E2 on day 2 is 32, and AFC counts are 4 to 5 antral follicles on the right and 2 antral follicle on the left side. So how are we going to stimulate? What should be our starting dose in this patient? If you want to know any other parameters, I can tell, but I think this is sufficient. The age of the patient is 27 and her weight is 60.
Ma'am, I would like to start her on 150 recombinant and 75 HMG.
Okay, so total of 225 units with a breakage of 150 plus 75. Dr. Niti?
I'll also be starting with the recombinant 150 and 75 HMG, because less than 38 years old, even if the AMH is low, that time it is not going to help if we start with, say, 375 or maybe a higher dose.
Okay, and Dr. Charu?
Yeah, I would, ma'am, go with HMG, like how Manpreet ma'am has already spoken. And I can add Gonal-F 75 to start with.
So HMG 150 and 25 Gonal-F.
Yeah.
Okay, so the consensus of the house is that we are going to start with 225 units in this patient. So in this patient, 225 international units of HMG was given. 4 follicles started growing, and by day 4, the follicles were around 14 millimeters. The antagonist was started, and on day 9, trigger was planned. Because the follicular size was between 19 to 22 mm. Trigger was given as a dual trigger. So, do you agree with the dual trigger in this case?
No.
Okay, so what trigger will you give?
We would give either Ovitril or the normal HCG trigger 10,000.
Okay, anybody else?
To get the better M2s.
Okay.
The E2 level is just 1329. So we are not expecting more than maybe 5 eggs. So why give a dual trigger in this case?
Dual trigger is to retrieve more M2 size. We want to get
dual trigger expecting less eggs, because it helps in the maturity of follicles which we are getting. So I would like to give a dual trigger in this patient. And it helps to get more M2s. But now if we see the picture, it is not showing as...
So the LH on the day of trigger was 1.65 and E2 was 1329. A dual trigger was planned and 3 follicles were retrieved after 35 hours. And out of that, only 1 was M2 follicle and a grade B embryo was transferred, and the result was negative. So now the patient wants another stimulation from you. So in the next cycle, what should be your protocol in the second cycle? Dr. Niti, what will you do to help this patient in the second cycle?
I would like to now make FSH and HMG 50-50 because we know that instead of giving us, because high LH in the beginning does help in people who have borderline ovarian reserve. And in this patient, we've already given more of recombinant like 150 and 75. So I would like to make it 150.
This patient have given HMG 225.
Now I would, okay. So when we are making HMG 225, we will I would like to make it then 300 HMG and do the same, I think, antagonist protocol. Not more than 300.
Dr. Manisha?
So I'll be increasing the dose by 75 IU only. That is the only thing I'll do. And probably I'll give her antioxidants. Ma'am, see, I believe that she should be given little antioxidants in the previous cycle. And probably we can prime the cycle before starting the next stimulation so that we get more eggs. Normally, this is what I do. I don't change the
estrogens. You will be doing priming with the estrogens.
Yes.
So what estrogen and what will be the dose of that estrogen?
I normally start from the previous cycle, day 21. I start with 2 milligram twice a day. And I give it till day 1 of the menses. Then I give a day wash-off period for 1 day. And then I start the stimulation by day 2.
Dr. Charu, we have 3 panelists. Dr. Charu, Dr. Manisha, and Dr. Niti.
Yes.
Ma'am, we have one more panelist, Dr. Shalaka.
I've just joined in, yeah.
Doctor?
Shalaka Mamidwar, ma'am.
Okay.
Yeah, I've just joined in. Yeah, hi.
Yeah, she's also there, ma'am.
Dr. Shalaka, we are already in the middle of a discussion of a case, and I think you have noted the case or not?
Yes, I have. I have
Okay,
seen it.
okay. So, Dr. Charu, your opinion about the second stimulation in this patient?
We would like to give the estrogens, and then the wash-off period should be 4 to 5 days and start the stimulation.
Okay.
Madam, for estrogen, the wash-off is not 4 to 5 days. For Ocipil, it is 4 to 5 days. For estrogen, it is just 1 or 2 days. Because when the effect goes off, more eggs, we normally give a wash-off period for 2 days maximum. Otherwise, the effect, there will be asynchronicity of the follicles.
No, in fact, the follicles would be synchronized by then.
No, but normally
and then we'll have the starting of the protocol.
This is the way, I don't know. This is the way I also follow, and I have also read in the books also. So this is the way the wash-off period is
also.
Your experience?
No, the synchrony of the follicle is also better in this.
Have you noticed that 4 follicles started growing by day 4 and they were 14 millimeters? Can this be the cause that the rapid growth of follicle in the first 4 days actually lead to less retrieval of eggs? So there has to be we have to see a dose where we should be getting the recruitment more, but the size less on day 4.
So it's a short follicular phase, ma'am. It's a short follicular phase. You're having a faster development of the follicle, ma'am.
Yes. So there the dose, increasing the dose is not going to help us in improving the number of eggs recruited in this case. Might be a lower dose or a minimal stimulation will help in such a patient. Do you agree with me?
Yes.
So I agree. That is the only point which I am seeing in this. Otherwise, the stimulation was all good. We all agree that the stimulation has to be done with 225 in this patient. But the only thing that the antagonists, that the follicles started growing on day 4 and they were 14 mm on day 4, that we need to suppress this follicle with an agonist in the prior cycle and do a stop agonist type of protocol so that the follicles should be growing at a uniform pace or a linear fashion. That is what my opinion is. The house is open for discussion.
Can I ask one question?
Yes.
Question. What was the day 2 size of the follicles?
Were they synchronous or not?
That is very, very important. The day 2 size of the follicle, if it is 7 to 8 mm on day 2, that these are the follicles which are growing very fast. So there we have to decrease the dose of FSH.
Otherwise, we can give antagonist for 3 days. And then we can start stimulation.
Suppressive type of thing, and then start with the stimulation part.
Yeah.
So,
agonist cycle also will be a better option in this cycle. A long cycle.
A long agonist cycle.
Yeah.
The suppression will be more. You never know how the patient is going to respond, but they say that if we have, they have studied an agonist versus antagonist cycle in the same patient, and the results are sometimes the same. So you have to do something with the doses, or you have to do something with the suppression of the follicles prior to stimulation.
Right.
This was the study done on 8772 IVF patients, and that what they found that the relationship between the initial FSH dose and number of available day 3 embryos was non-linear, and the initial FSH dose was negatively associated with number of available cleavage stage embryos, and when the initial dose was more than 200 units. So we have to always see that we should not be giving higher doses to get more eggs in all the cases. So this is again, ART is an art, and we know that we have to, at the end of the day, we need a one good pregnancy. So our stimulation should be designed like an art, so that we should get the results by maximum. And AFC count and AMH, these are the two things which have been found to be the best predictive of the good ovarian response. However, the success always depends upon the good quality oocytes. So, pardon?
Ma'am, one point I just want to make, ma'am, I'm just saying that you have said you should decrease the dose. But ma'am, if you look at the Bolagana also Poseidon, they also say if the response has been poor in the previous cycle, then at least you can
step it up. At least 75.
Step up.
Yeah, it all depends upon your previous stimulation
300.
response. Yeah, that is okay.
Yeah.
If we had started with 300 in the first go, but what we have found is, we have found that the follicles are growing very fast in this patient. And that is why in this patient, the individualization has to be done in every case, right? This was the case where we have started with 225. And then we got the follicles 14 millimeters by day 4. That was the point I wanted to highlight.
And in normal cycles, you should get 12 to 14 at day 6 or 7. So
Yes,
we are faster
exactly.
in this. So this is the catch point of your question.
Yeah.
You're right. Yeah.
So all the journals, they are pointing towards only one thing, that it's time to stop using very high doses, even in low responders. And it has been found that the FSH dose did not affect the ovarian response in terms of total number of follicles retrieved and within the age group. But they found that the lower the FSH dose needed in the lower age groups, and in group of patients less than 35, a positive effect of FSH dose on oocyte yield. Despite that, for patients who are around 38 years, there was a negative effect on FSH dose on embryo quality and blastocyst formation rate, and an increase in the cycle cancellation rates. So we have to actually individualize every patient according to the number of enteral follicles and according to the previous cycle response. So coming to the second question, let's go to Dr. Mandeep has highlighted that the interval between the last dose of antagonist and the trigger should be around 12 hours.
12 hours.
In your clinical, pardon?
12 hours, you said.
Yeah. In your clinical practice, what you all do? Dr. Niti, we'll start from you. What is the
I keep at least 6 hours.
Antagonist and trigger? Pardon?
6 hours. At least minimum 6 hours.
Minimum 6 hours. Does it make any difference?
No, I haven't found any difference.
So if you have given an antagonist in the morning at 12, so how can you plan a trigger at 6?
I plan a trigger around 6, and I have found that we get the same number of M2 sites also. Like suppose if I have to trigger at 10, then I put the antagonist at 4. So I keep a gap of around 6 hours.
No, if you have started your antagonist in the morning, or you start it in the evening?
I give it in the evening around 6, and on the day of the trigger, I prepone it to 4, and then I trigger it at 10. So it's 6 hours of.
Dr. Manisha? Dr. Shalaka? Dr. Manisha, yeah.
Ma'am, we give an interval of 12 hours between antagonist and trigger. We try to give that much difference between trigger.
If it is more than 12 hours, then?
Ma'am, normally we don't give second dose of antagonist. And it will not be, ma'am, because we try and give an antagonist by like 12:31. So any which way we start giving our triggers by 10:30. So it comes out to be same only. 11:30 we start our triggers.
And Dr. Shalaka?
Same, madam. I give a gap of around 12 hours.
Okay. Dr. Charu?
Yeah, the same one, ma'am. Already answered.
So nobody gives a trigger and antagonist within 4 to 6 hours, except for Dr. Nitin.
6 hours, not shorter than that.
Yeah, let's see what the literature says. There was a study which was carried on 53 patients, and they say the mean interval was 4.6 to 27 hours, ranging from 1 to 12 hours. And there was actually no correlation between antagonist and agonist interval and the oocyte recovery rate. So the conclusion was that that does not matter whether you give it at 4 hours, 6 hours, or in less than 12 hours. So how far is too far? This is another study which does time interval between GnRH antagonist and agonist trigger matters. And this was a study which was done on 413 patients, and they divided the whole study in 4 groups. So the 12 to 14 hours, 7 to 10 hours, 5 to 6 hours, and 2 to 4 hours. And they found no difference. There was no correlation. And another study was, does the time interval from last antagonist matter? And answer was again the same. And this is very interesting study. GnRH antagonist protocol with cessation of cetrorix. So they have stopped cetrorix on the last day. Improves the embryological outcome for patients with sufficient ovarian reserve. So this is one of the latest study I found. This was done in 2021. And what they have, their conclusion was that GnRH antagonist protocol with cessation of cetrorix on trigger day improves the embryological outcome for young patients or patients with sufficient ovarian reserve. So anybody of us has tried this?
I have not tried.
No.
No, nobody has tried it. But this is something which we can try. I don't know whether we will be, but they have not found any premature rupture of oocytes in this patient. But just a single study I found, I wanted to actually discuss it with you. But as it is, the time relationship between the antagonist and agonist, I think it is a myth now. Because I have found so many references that they are saying that there is no relationship between the that. So this is again a myth. And the truth is you can give antagonist and you can give agonist trigger at any time. That is what the literature says. Over to Dr. Manjushri for her presentation. Dr. Manju?
Yeah, I'm here.
Yeah, I'll stop sharing my slides.
Okay, yes, I'll share. My video is not visible or it is visible?
Just hold on. I'll be stopped.
You are not, yeah, now you can. We can see now.
Yeah. Just wait. I'll share my screen. Just give me 2 minutes and I'll do it. My internet is really giving me trouble.
Shall we go ahead with the next question then?
Yeah. Is it visible?
No, not visible.
Your screen is not visible.
Your screen is not visible.
Okay, just wait.
What you can do, till the Anupama takes her, you can send your the PPT email to this Corona people.
Okay, can you just send me my mail ID? Anyone can send?
I'm sharing it in the chat
Dr.
box.
Anupama, you can take the next.
Dr. Manju is arranging her slides.
You can take the next case.
One more question like this only.
You can take
do
the next
we get a progesterone level on the day of ET? On the day of embryo transfer? Pardon?
I do on the day of trigger, just before giving the trigger.
On the day of embryo transfer in FET cycles, do you do?
Not on the day of embryo transfer.
You don't do progesterone levels on the day of embryo transfer?
I do serum progesterone levels just before the trigger. And if it is like less than 1.2, I would like to transfer it. I don't do 12 hours after that also. Because many people do 12 hours after that. So 3 nanograms.
Dr. Charu, we are talking about frozen embryo transfer cycles, FET cycles. Are we doing serum progesterone on the day of FETs?
Yeah,
on the day of transfer?
No. I'm not doing it, ma'am.
I
are
am not
not
doing
doing.
either.
Dr. Manisha, you are not doing.
Not on the day of transfer.
Not on the day of, just before starting the progesterone.
Yes, we are starting out. Just before starting the progesterone, we are doing it. Yeah.
Okay, and we are not doing it on the day of transfer. Dr.
No,
Niti?
no.
I'm not doing on the day of transfer. Earlier we used to do it, but now I don't do because I completely give injectable IM progesterones, and the levels will be, that is the maximum progesterone level that you can attain, number one. Number two, with the subcutaneous progesterones which we give, or the vaginal progesterones that we give, the serum levels don't reflect the actual progesterone levels which are there in the uterus because of the uterine first pass. So I don't do it on the day of the progesterone, on the day of the embryo transfer.
On the day of the embryo transfer. And what about the type of progesterone? So you have already mentioned that you are using intramuscular preparations.
I use intramuscular oil based.
Intramuscular,
Like, even if the levels are low, we are going to switch to that only.
Okay.
So just with an
So
added extra
everybody
test
in the
increases
house
the
agrees
cost.
that we are using intramuscular preparations?
Yes.
And if the patient is not compliant with that, or allergic to that, or there are lump formations, then?
Yeah, so I have patients who have little allergies. They have fever with intramuscular progesterone. So then I switch over to gels, vaginal progesterone gels. I give them like Credon gel or something twice a day, and they take it till the day of embryo transfer. In the morning of the day of transfer, they take it at around 6 in the morning, and we do transfers by 12:32 in the evening.
Okay. Dr.
And
Chowdhury?
dydrogesterone orally 10 mg also I give when the patient is having some allergic or really lump formation and really not suitable. So I give gels as well as tablets, but then I give TDS 10 mg TDS dose. And it gives good results.
Yeah, it gives good result with vaginal gel also.
Yes.
So you are giving 2 preparations of progesterone, or are you going in for?
I'm using 2 preparations, oral as well as vaginal. And the vaginal one. Yes.
No injectables.
No injectables if the patient is really, having lumps or fever and she's not tolerating it. Otherwise, I give injectables only for 5 days if I'm doing a blasto transfer, and then I change over to Dufiston and vaginal preparations, and then no more injections. So I just use injectable for 5 days.
Okay.
Is my protocol.
And Dr. Niti, you?
I give oral dydrogesterone, and till the day of the transfer, I give twice a day with vaginal 400 twice a day. And once the transfer happens, I give dydrogesterone TDS. Along with that, I give one injectable, which is the parenteral IM.
And then you stop using that vaginal progesterone?
Yes.
From the embryo transfer?
From the day of the transfer.
Yeah. And Dr. Manisha?
So I give injectable progesterone for 5 days. I do my transfer day 5, the blastocyst on 6th day of the injection. Then I switch over to Dufiston and vaginal gel, twice a day gel, and BD Dufiston I give.
Actually, I have started doing now progesterones on the day of transfer. I was not doing it earlier, but since the literature was saying so many things, so in 1 or 2 patients, the progesterone was very, very low in spite of giving that intramuscular preparation. And there I added HCG and I got a pregnancy in those patients. So in 1 or 2 patients, I thought that this might have helped me in getting the result, but otherwise in all the rest of the patients, with intramuscular preparation, the serum progesterones are very, very good. So there is actually, you feel like that this is basically an extra test you are offering to the patient. But in 2 patients, definitely the progesterone level is very low in spite of giving intramuscular preparations. And there I added HCG every 4 days, and that in those patients I get the result. I don't know why progesterone resistance was there in those patients.
Yeah,
That's
adjuvants
not
and
my
IV.
experiences, but there are
First line,
a
adjuvants
lot of
and IV.
literature
Yeah.
on getting serum progesterone on the day of ETs.
Yeah, yeah.
So
Just
that
I'm not
is
able
I
to see
wanted to know
myself.
whether it is a myth or a truth, and too high levels of progesterone or too low levels of progesterone, both are detrimental. So I think Dr. Manju is starting with her presentation. Let's over to Dr. Manju.
Dr. Manju, your screen is getting shared. Please, you can check it.
Yeah.
I'm really sorry for this.
Ma'am, you are logged in from two connections, I guess.
Yeah,
That's why the voice is echoing.
yes. I'll just switch off one. Is it okay now?
No, ma'am, it's still the same.
Ma'am, actually, you might have logged in with 2 devices, ma'am.
Yes.
Yeah, so if that is the other one is a phone, you can just
Dr. Manjushri, just switch off your phone. Yeah.
Yes.
Yeah, now it's good.
Yeah. First of all, extremely sorry for that bit of catch in my net connection, which was going and coming, and this sharing of screen. So we'll again, at the outset, I would like to thank IFS Vidarbha chapter, Punjab chapter, for giving me this opportunity to be amongst you all, esteemed panelists, esteemed seniors, and my friends. And today we are discussing lots of drugs. I said, why not to break the myths about adjuvants in IVF? Lot has been spoken, and myths had been clear about agonist, antagonist, and all the drugs almost have been spoken by Dr. Manmeet also, and letrozole in detail. So coming to my all panelists, I welcome you all. So my first question goes to next, please. I think Corona people need only to help me out. Yes. I would like Dr. Charu to put it may not be a myth. We may come to some consensus whether we really need to use all these drugs in our IVF practice. What is the evidence-based protocols, and this all, is it really helpful to use in a patient, or it is just a waste of money? So Dr. Charu, can you put a light on role of inositols?
Yes. In PCOS patients, we try to use these drugs like myoinositols and metformin. And there is a Danish study which has compared the role of myoinositols and metformin. So they have said that in conclusion, both inositols are useful. They help basically when there is hyperinsulinemia, hyperandrogenism, anovulatory cycles or irregular cycles, hirsutism. When the patient comes, you have to select the patient properly. You have to do the serum insulin levels if they are more than 10. And inositols have their own role, and metformin. But when we see the difference between the two, with inositols, we have found that there is a good tolerance. Insulin sensitization is increased. There is a hormonal imbalance. The oocyte formation with vitamin D, which has been added, is better. And the weight loss is not much, but the side effects of bloatingness and GI side effects are lesser with inositols. But metformin has been found to have a bigger advantage. It also reduces the BMI of the patient. But both of the drugs, before using both the drugs, inositols and metformin, we have to have the lifestyle modification, which is the key role in PCOS patients. And metformin also reduces the miscarriage rates, and it can be continued till 5th month, 6 months of pregnancy. So if you're going for an IVF, we would comparative studies have shown that metformin gives you better outcome by using metformin. And when you have to start metformin, because of the side effects, sometimes we have to leave it. So the ideal dose of metformin is 1500. So you have to step up the dose. First, as soon as the patient enters, what we do is 500 mg BD or 500 mg TDS likh dete. So patient is not willing to take that high dose immediately. So you have to start and step up metformin. That is the clue which I want to give to. And if it is inositols, it is undergiven. The dose of inositol is 4 grams. So it is twice. So you should have proper dosage. The type of PCOS, the obesity, and the criteria. And then the studies have proven metformin is little better in this Danish study, which was in 2001. Exactly, I don't remember the year, but yes.
Excellent answer, Charu. So talking about myoinositol, it has an influence on different pathways. and it seemed to significantly modulate steroidogenesis. And definitely it has an effect on ovarian and non-ovarian tissue, and it improves the M2 oocyte. And the role of myo-inositol is not only in PCOS. Just see what our study, next please, just see what studies are saying. This is also in poor responders, and in this study, it's a very good study which M2 oocytes are significantly higher if we give to poor responders. Next, please. P-value is less than 0.05. So effect of supplementation with myo-inositol plus melatonin and oocyte quality in women who failed to conceive in previous IVF cycle for poor oocyte quality can also be given with inositol. So it's not only in PCOS, various studies are coming that you can give even in poor ovarian reserve, because it is acting at an ovarian level where steroidogenesis is affected, and it acts as an androgen sort, and also it is effective at non-ovarian level where it also helps in against steroidogenesis. So definitely inositols is yes in our basket. So next please. And data clearly shows this. Next please. Now my next question goes to growth hormone to Dr. Pranita Jitnevis. Dr. Pranita is there? No? Who can take up the question there? We have Dr. Manisha Bhagat.
And Dr. Pranita has gone for emergency.
Okay. So anyone would like to take up, or should I just tell
Dr.
about
Manisha,
it?
Dr. Manisha is
Dr. Manisha. Yeah,
Okay,
please.
So ma'am, with growth hormone, initially the studies were very promising, and we started with 4 IU from day 2 of our cycles. So we have seen in poor responders probably a set of patients who responds with growth hormone because it increases IGF factor 1 in the follicle fluid. But ma'am, what I personally feel that it is not that effective. It is quite expensive. Probably for some people, they feel that the results have been there and they can use it. But I personally don't use growth hormone. The funda was, first of all, when to start. There are some studies which say that you start in the previous cycle, day 21, and then you see the effect because it will increase the follicular recruitment and everything like testosterone. And the studies nowadays says that you start from day 2. So we used to start from day 2, and they used to give it till day of the trigger. So probably it will increase the number of oocytes in some patients like testosterone, but whether that will lead to a pregnancy rate which is significant, that I don't know. The studies are very conflicting.
Next slide, please. So, Dr. Manisha, you had excellently told about growth hormone. It is proposed to have a modulatory effect on FSH on granulosa cell. Next, please. But what our literature is saying, addition of growth hormone adjuvant therapy to long down regulation protocol in poor responders undergoing IVF, it is saying there is no significant difference in cumulative pregnancy rate in 240 low responders. Next slide. So one more study is also saying no evidence of increase. Just go to the conclusion. No evidence of increased chance of live birth. Next, please. So another study, growth hormone nowadays is said to have effect on endometrial receptivity. So it may not be the oocyte or number of M2s, but it really have an effect, little effect on endometrial receptivity. But do we have that much amount of money? And no research till now has been done. So maybe this is an area of research for all doctors and scientists who are sitting here. Next, please. And similar study, we will come to Cochrane review. Use of adjuvant growth hormone in IVF treatment protocol has uncertain effect on live birth rate. Similarly, ASHRI is also saying use of adjuvant growth hormone before or during ovarian stimulation is probably not recommended for poor responder. So here we drop down this growth hormone from our basket. We have picked up myo-inositol. So let's go to another adjuvant. Next, please. Next slide, please. Testosterone. Dr. Manisha again.
So,
Can you
ma'am,
take up?
testosterone.
We have only
sure.
3 panelists. I think third one is doctor.
No, ma'am. So I'll do, ma'am. Testosterone is another kit which we are exploring. So if you look at the T transport trial, which has been conducted and the results which are available now in 2023, it says that there is no increase in number of oocyte, there is no increase in number of M2s, there is no increase in live birth rate. On the contrary, they say with testosterone group, there is more cancellation rates and there is no change in oocyte maturity or a decreased transfer cancellation. So what they say that there is no role, but probably we'll need more studies and more researches. So if you look at some other RCTs, like in 2015, the RCT was done and they said that if you give 10 grams of testosterone starting from day 5 to day 21, it is beneficial because it helps in the follicular recruitment and it probably acts on that level and increases the number of the follicles which are available for doing ICSI and all. So it does increases M2, it increases the number of embryos formed. So the studies are very conflicting. Whether to go one way or other, we don't know. Because if you look at the T transport trial, they say that keep it inside the box, don't use it, there is no benefit. But ma'am, we as doctors are using it. I personally use testosterone 1 month before the stimulation cycle in poor responders, because I have seen results, probably not too much in live birth rate, but definitely cycle cancellations have been dropped and we get little more mature oocytes.
Yes,
I agree with you.
Let's see what our literature says. Ovarian features, a very good study by Chung Hoon Kim. Ovarian features after 2 weeks, 3 weeks, and 4 weeks of transdermal testosterone gel treatment and their associated effect on IVF outcomes in poor responder. However, there is no significant difference in live birth weight in women. Was found in women who received 2 weeks of testosterone pre-treatment. But next, please. If you had given pre-treatment for 3 weeks, definitely there was a higher live birth rate. RR was 2.29 and similarly CPR was 2.32. So conclusive remark from this study comes as testosterone therapy seems promising, as we all clinician. We may not be doing a RCT or something, but we are getting a very promising results from this testosterone gel, and it seems promising to improve the success at IVF in poor ovarian reserve. So at least we have one testosterone gel again in our basket to be used for POR patient, but use it for 3 weeks prior to your stimulation date. So it should not be 2 weeks trial. It should be 3 weeks or 4 weeks, a month before. If your stim start date is first, then at least a month prior, you need to start this gel. So similarly, androgens in women identified, what Cochrane says, in women identified as poor responders undergoing ART, pre-treatment with DHEA or testosterone may be associated with improved live birth rate. DHEA, I have not taken in this basket because it has proven, it doesn't have any myth. So DHA, we all know, this is very, dehydroepiandrosterone is very, very important drug and we all give. So that drug I have not taken and spoken about. Ashtree also says use of testosterone before ovarian stimulation is probably not recommended. But what the second line it is giving is insufficient data on dosage, administration duration and safety. We cannot recommend testosterone use. So they are not saying absolute no. Even Ashtree is not saying absolute no. So we all can work on this drug also, and we can use this drug a month prior or at least 3 weeks prior. Next, please. DHA, Dr. Niti?
Yeah, ma'am. DHEA is a steroid from the adrenals. It is from the zona reticularis of the adrenal gland and also from the theca interna cells of the ovary. The main role of DHEA is in poor responders. Its main role is to increase the androgens, and as we all know, in the early recruitment and initiation of the growth, these androgens are needed because they have to be converted into estrogen. So it has been found that DHEA pre-treatment in poor responders, at least for minimum of 3 months prior to stimulation, leads to more number of follicles are recruited. And also they have found that at the microscopic level, the cumulus cells are better, the oocyte quality has been found to be better, and also the growth is more because it increases the intrafollicular IGF-1 levels. So it has been found to increase the number of oocyte, and usually they say that when they have studied the CC complex also, it is found to be better. So the dosage is 75 to 90 milligrams at least 3 months prior. The dosage which we use is 75 milligrams 3 months prior, and during stimulation also we can add on along with our gonadotropins.
Yes, excellent answer. Next,
Ma'am, just to add to this,
carry on.
In this, if you have given vitamin E also to this patient and vitamin D3, then also the quality is improved a lot. But I don't agree that DHA increases the number of follicles. The rest of the things, practically whatever small data I have been doing in my IVF, it does not increase the number of oocytes, but the quality definitely is better.
Quality. So maybe more number of
good quality.
Similarly, so we may say that as you have Niti rightly said that it has an effect on insulin like growth factor 1, and that's why it augments the estradiol production in granulosa cell, and it acts as a precursor for androstenedione and also the testosterone in ovarian theca cell. And dose is 75 milligram per day, and to be used, very rightly said Niti, 12 weeks prior. So it is not that a walk-in IVF. I really don't want to do a walk-in IVF. Patient is coming and you are just taking in cycle. So don't do that. Properly prime her ovaries, properly prime her uterus, get a total investigation done, get into the totality of a patient and then treat it rather than walking IVF. So next slide, please. Similarly, next slide. So these are few RCT. We will come to Cochrane review. Cochrane meta-analysis also performed a sensitivity analysis including only RCTs, including poor responders, and found that DHEA pre-treatment was associated with increase in cumulative pregnancy rate. So this we can pick up in our basket. ASHRAE also is saying use of DHEA before during ovarian stimulation is probably not recommended for poor responder. They have written it conditional because there is currently inconsistent evidence that adjuvant DHEA used before and during ovarian stimulation improves ovarian response in terms of live birth, ongoing pregnancy rate, or poor response. So maybe they have written conditional means if data supports it. Maybe next ASHRAE, we may say that DHEA, so much of doses 3 months prior, and this all things will have a stamp and seal by ASHRAE, and we will be using it more effectively. Today also, we all are using it. Next, please.
I want to add one more thing to this, ma'am. May I add?
Yeah, surely.
Yeah, there was a study which I was going through, and they said that we need to get DHEAS levels done in poor responders. In patients in whom the level was less than 180, in those giving DHEA was beneficial. In those in whom the level was more than 180, there was no role of giving DHEA because
but how you
it is
do
a precursor to it.
How you do it, Niti?
The blood levels, ma'am.
Blood levels, but dehydroepiandrosterone steroid.
Sulfate, DHEAS levels.
Sulfate.
Yes.
So is it available in India?
They have
no
this
idea.
Was basically an international study. This was the only study which did use this as a cutoff, as a criteria
so
to give or not
in future, we may have these levels to be done in India also, and we may have a better insight into whether to use DHEAS or not. Fine. So, next, please. Dr. Shweta is there. Shweta Nanda, is she there? Immunoglobulin and immunotherapy. Anyone would like to take it up?
Madam,
Example, yes.
Yes, I do use immunoglobulins, especially if I have recurrent IVF failures. I have patients with history of recurrent pregnancy losses, and I give them immunoglobulins, Interglobe, like once every 4 weeks. And
IVIG or Bharglobe? IVIG?
No, Bharglobe I give.
Bharglobe is okay.
Yes, that is what I.
This was about IVIG. So next slide, please. Bharglobe, many of us are giving. So IVIG treatment for repeated IVF, ICSI failure and unexplained infertility. There was a systemic review and meta-analysis by Yang Chen, and it has 10 studies, total 835 patients. And the final outcome, the quality of retrospective study was variable, including mixture of patient, recurrent implantation failure, and unexplained infertility. Next, please. So there was no consistency in the group of patients to comment on that study proper, and role of immunotherapy is in vitro fertilization with recurrent pregnancy loss. The available medical literature shows a very controversial result about the role of immunotherapy when used for improving reproductive outcome. The study did not show a role of immunotherapy in improving the live birth rate in women undergoing IVF treatment or in prevention of idiopathic RPL. Currently, it should be used in context of research only and should not be used in routine clinical practice to improve reproductive outcomes. Next, please. So this is what we want to pass on the message. Next, please. So even lead therapy after multiple recurrent implantation failure should be used only for research purpose. Next, please. ASRM. What ASRM has to say about this is there is insufficient evidence to recommend IVIG administration as a part of IVF to improve IVF outcome. Subpopulation that benefit from treatment may exist, and these are the cases where already they had either APLA positive or whether there is a already some immunomodulation is to be needed because of immunological cause of recurrent pregnancy loss or recurrent implantation failure. So you must have for a patient with recurrent implantation failure or previous multiple abortion, you must have an APLA study before and then only plan a line of management. Next, please. Intralipids. Dr. Shalakha Mamedwar, she was there some time back.
Yes, ma'am. She has gone for an emergency actually.
Okay. So like any of my esteemed panelists can take up intralipids?
Ma'am, last. Hello.
Dr. Niti?
Ma'am, intralipid is basically given in recurrent implantation failures. We were using it, but we don't use it anymore. In patients who have recurrent implantation failure, we would give it in one cycle prior to starting the frozen embryo transfer. And then during, say, day 8, day 9 of estrogen, and one intralipid, most probably one day after the embryo transfer. And this is just to suppress the immunity. This is basically we are taking the fact that this functions just because the embryo is considered to be a kind of an immune factor for the implantation. This takes care of that. But presently, I'm not using. We were using some 3-4 years ago. At the moment, we're not using.
Okay.
I'm using it. And I'm using it for people with recurrent IVF failures, like 3 failures, 4 failures. And I started on the day of embryo transfer. Not prior. Earlier, I used to try it prior to the transfer, but now we've started it after the transfer. And once the patient becomes pregnant, after every 3 to 4 weekly, we give it. Till 24 weeks.
In my clinical practice, I had a patient with previous 9 IVF failure, 6 IVF failure, and we had given 8 days prior to embryo transfer so that her immunity is suppressed. And then once a beta HCG is positive, we give every 21 days, every 3 weeks, till you get a cardiac activity until that pregnancy goes to 8 weeks, 10 weeks time. So I had a good number of cases of using this intralipids, and they are really giving good results. Maybe we need to still work on it, have a RCT or some type of studies to publish the results for it. Next, please.
Manju ma'am, I've never used intralipids in RIF patients also. So I don't have experience with this.
Okay. But I think, Charu, it is a really good drug because when you are frustrated, and I had really got a wonderful results with previous 9 IVF failure, 6 IVF failure. So it is really worth trying. That I will recommend. So let's see, please. Next, please. So this is another study by Dina and Deki. Overall, 296 patient has been given with intralipid, and conclusion is it did not increase frequency of chemical pregnancy. However, findings related to ongoing pregnancy and live birth need to be investigated further. Next, please. Next study. Yeah. What ASRM has to say, there is insufficient evidence to routinely recommend IV fat emulsion for infertile women pursuing IVF. Additional studies are needed to identify population where benefits may exist, but till date not proven. But clinically, I think it is a proven thing. Next, please. So we had some questions which are just a rapid fire question. This may not relate only to drug, but to conclude any IVF panel, I think these questions are very important. So should I carry on or should I stop? I have around 4 to 5 questions. What's time?
Yes, ma'am, we
can continue.
Yeah, we can continue. This is a very interesting question, and all our panelists, even I am going to answer this. So like we all will work together, like which protocol and where. So like agonist protocol, long antagonist protocol. Sorry, it is long agonist protocol, and second is antagonist protocol, and third is very important protocol which I would like to discuss is stop agonist antagonist protocol. So agonist, Niti or anyone can take up, where you really say no, it is not gone by, you need it now.
Endometriosis.
Endometriosis. Yes. Great. Sushma ma'am, long protocol.
1 minute. I was busy somewhere. Okay. Just I will get the question. You can ask again.
Like controlled ovarian stimulation protocol we are talking of. We have agonist, we have long agonist or antagonist, or third protocol I'll be taking. So where you think that long agonist protocol is important?
And endometriosis.
Endometriosis. Great. And anyone else want to add something?
Endometriosis, ma'am.
Yeah.
I would like to add, it will be in the cases of endometriosis, adenomyosis, and severe PCOS where the LH levels are very high. It has been found to be good.
Also in some cases of poor responders, even though we say that the antagonist protocol is good. I had tried it, even just one patient is under me. Last month, no good follicles. Now at least I'm getting 4 follicles.
Great.
I'm happy with that.
That was very important thing that I wanted to say, because when I started with my German colleague, we used to have all long agonist protocol. With antagonist coming in way, we have almost stopped long agonist. But again, we are going back to long agonist, especially in adenomyosis, as Charu rightly said, endometriosis. And third is poor ovarian response people. Because here we have a very good synchrony of the follicle. So if you have 4 follicles, you are going to get those 4 follicles. But what happens in your antagonist protocol? If you have 4 follicles, one may be bigger, second may be another less bigger, and then you will lose 2. So at the end of the day, M2 will be 2. But with a poor responder, long agonist protocol, you are going to get all follicles. Maybe 3 will be M2, if not all. So that is poor response is one of the POR patient. We should go with a long agonist protocol. Now we will come to stop agonist antagonist protocol. Next slide, please. I think future should belong to, next slide, please. Future should belong to a long agonist stop antagonist protocol. And there is a protocol shift now. I would like to say why long agonist protocol was giving excellent results and pregnancy rate. Why antagonist has come in research? Because we had more of a ovarian hyperstimulation. You all agree that agonist protocol gives a uniform cohort and a very good M2 in normal responder. But in same patient, if you use antagonist, you are going to get a follicles which are of different asynchrony of the follicle is there. And secondly, number of M2s are less in antag protocol. But because of fear of OHSs, we all are going to, and freeze all policy. So we all are going to antagonist and using agonist trigger. But a wonderful protocol has come, agonist, stop, antagonist protocol. This will avoid our OHSs also, and this will give a wonderful result. So maybe to me, logically, future belongs to this. So what is this protocol? And there was a study where 345 normal responder patient has undergone this type of protocol, and cycle cancellation was significantly lower in this protocol. Next, please. Next slide. And pregnancy rate in patient who shifted to antagonist preceded with agonist was almost 57.8%. Concluding this, a protocol shift from a failed ICSI cycle with either agonist or antagonist protocol, it won't affect the outcome. But next, please. So now come to what are the limitations of antagonists? There is a difference in synchrony of the follicle. Effect of elevated LH level in the follicular phase. We cannot take care of it because we are starting antagonist on day 4 or day 5 or day 6. So definitely day 2, if LH level is very high, we are not taking care in antagonist. So definitely that will have a blunting effect or a improper effect on the folliculogenesis, and direct effect of GnRH antagonist on extra pituitary tissues like corpus luteum, endometrium, ovary, embryo, and potential pharmacological differences among the existing compound we really know. This is very important for poor responder and Poseidon group 4. Next, please. So, present study, the number of embryos in GnRH agonist top antagonist group was significantly higher with antagonist in comparison to only antagonist group, and percentage of AB quality embryo agonist in the GnRH agonist top antagonist group were significantly higher. And this protocol starts, you start with day 21, 0.5 milligram of leuproid, 4 milligram, 4 ml, and then day 2 of your step, you have to stop on day 1 of the cycle. You stop your agonist, you start stimulation from day 2, and from day 2, you treat that cycle as your antagonist cycle. So this is quite similar to we are using estrogen for the follicular late luteal phase. This is quite similar to that. But estrogen doesn't suppress all FSH, LH, which is there in the second half of the cycle. Even progesterone, which is very, very high, it doesn't suppress that. But with usage of your agonist, you can take charge of the ovaries. Ovaries will calm down totally. And after that, when you won't have a residual follicular cyst, first thing, you won't have a residual follicular cyst. You won't have a high progesterone level. You will not have a asynchrony in your stimulation. So these 3-4 things are really going to give you you will have wo bolte hai na, ek peg free. So no OHSs, but good pregnancy rate. This is what I am seeing after. And I must thank Sushma ma'am for giving me this opportunity to go through all literature once again and finding this gem of the protocol.
So
and I have put my 2 patients on it.
Yeah.
Next, please. So, next, please. This is the same study which is going on. So, this is definitely stop GnRH agonist, GnRH antagonist protocol is giving a different insight in the ovarian stimulation for IVF. And it has all advantages of long suppressive effect of GnRH agonist, and it is a valuable addition to our armamentarium of ovulation stimulation protocol. It allows cycle programming, better follicular synchronization. Next, please. And it is also very useful, successful in poor responders, Poseidon group 4 poor prognosis patient, those with elevated peak progesterone level. Charu, this is for you. Those with elevated peak progesterone level, poor embryo quality or repeated IVF failure. Even LH level is going to be suppressed. Even if you are doing it for PCOS patient, you are going to have a LH level which is already suppressed. By the time you reach to day 2, LH
so it's a better protocol. Yes.
Yeah. Next, please. Next, please. So this was about definitely agonist, top, antagonist. Another question is pre-IVF hysteroscopy. So what everyone has to comment on it.
Ma'am, not for all patients.
Not for all.
Selected patients.
I'll
For
tell
all
you.
patients.
I'll
For all
tell you.
patients. For all patients.
For all. I am for all. I'll tell you
Yeah,
today only I
because
did three
I will
hysteroscopy.
explain you because always there has been discussion.
Yes.
And there are studies also that they are not, all are not in favor of doing IVF pre-IVF hysteroscopy. See, you must understand when we are doing IVF, we are spending a lot of things on this thing. And we are not going to know whenever we are placing the embryo these are very special things in a mother's womb, we should understand how it looks microscopically. Many times there are micropolyps, there are so many things are there, minor adhesions are there. So this time you are get stuck and you are not getting results. So why not to do only, it's a very simple, you have to put a 2.9 mm hysteroscope in the uterine cavity. You have to see the magnified view of the uterus. So you are going to see the magnified view of your uterine cavity. You will get to know the blood supply, how it is. Even though there are ultrasounds are there, but it is totally, you are already getting complete histology in front of you. Secondly, you are going to get to know the pathway, whether there is any problem. Sometimes I will show many videos. There were some Nibothian cyst which was blocking the internal os. So these are so many minor things you can get with the hysteroscopy. So I am in favor of doing pre-IVF hysteroscopy.
Yes, yes. I second to you, Sushma ma'am. Absolutely, I second to you. Because today only I did 3 hysteroscopy pre-IVF and all 3 were absolutely normal ultrasound wise. And there was literally a good vascularity and everything was appearing good. There's no need. But I said, no, let's put a... And as she said, there was a multiple micropolyps were lying there. And secondly, one patient had a very bad vascularity. One patient has a dimpling, which was of just like septum, broad-based. And one, like in the same patient, there was a T-shaped uterine cavity. So at the same sitting. Otherwise, also everyone is doing mock ET, isn't it? So why not to just put a scope? I always tell to my patient, जब आप बेबी को घर पे लेके जाओगे, रूम तो साफ करोगे ना? So why not to do that and put an embryo in a very clean atmosphere? Have a vision, like even chronic endometritis, you cannot diagnose with your 3D, 4D, any ultrasound, you cannot diagnose. With the best of the sonologist. And at one sitting, you see clear and come out. Do a mock ET also. And this is really giving wonderful success rate. So I think we too are in favor. Maybe
and basically, see, there are, Dr. Manju ma'am, there are so many studies also. They are saying that there is no need, but I always say you should study because they are studied there at their site.
Yes.
And we are in India. In India, we are getting a lot of patients with the chronic endometritis, tuberculous endometritis. So we should study from our side. So that is very important.
True, true. I fully agree. I do it. Another question is, next, please. Please, next. Hysteroscopic PRP installation in thin endometrium. Everyone's opinion.
I have done it in 2 patients, ma'am, and I have got pregnancies in both of them. So it is beneficial. Those patients were not forming endometrium on the usual HRT cycle with 12 milligram up till 12 milligram dose, and they were not candidates for ovulation induction HRT. So in 2 patients, I did hysteroscopic PRP. Those patients never had endometrium more than 5 mm. With PRP, it went up to about 6.57 in both of them, and both of them conceived and both of them had twins. Excellent. So with 2 patients, I've had the experience. I've not used in more numbers, so I really cannot give much of a...
Excellent. But you had got a pregnancy, which otherwise would wear negative. So definitely you are towards positive side. Charu?
Yes, I agree. PRP is good, and the technique of PRP is very important. When you are putting it, you should be. You can use the OPU needle also to inject that, and it should go 2 millimeter in the cavity, and you can inject at different places, and you can see a little bit of blanching. So the technique how you're doing PRP is more important, and then you get good results. Some people don't use proper technique and then they say PRP is not useful. We have few case studies and we have found a very good result.
Excellent, excellent. I agree fully. It should be in the basal layer of endometrium. People are just putting through IUI cannula. How can it help? It is not, maybe little bit of it will get absorbed through endometrium, but it has to reach where? It has to reach to the basal glands of the endometrium. So if
So
you
the vascularity.
yes. So, and vessels also and glands also, so that it has to act there and then form a very good endometrium with a good vascularity and good glandular endometrium. So definitely it has to be subendometrial at the basal layer of endometrium. So putting PRP in the through IUI cannula doesn't help. It has to be through hysteroscope with OPU needle into the subendometrial region, as Charu has rightly said, around 2 millimeter. A practical point is you have a bevel of OPU needle,
Yes,
and you have some serration.
Right.
And you have some serration. So your bevel has to go completely. Little bit of serration also. Don't just put the whole needle. So little bit of serration, and then you have the point where you can put it. Next, please. So anyone else want to add anything for this?
We are also doing at Omega. We have been doing a lot of patients with thin PRP, thin endometrium. We have been doing this subendometrial installation, and we have a study also which has been published recently, in which 50 cases we had taken. And a lot of them, around I think 38% of them had conceived after a PRP installation in the next cycle, and the endometrium was better.
Yes.
And exactly the same technique as Charu ma'am is saying, that the OPU needle, especially the Reproline needle, is very good when we are doing this hysteroscopic PRP, and it is really helpful.
My PRP needle is a way of manufacturing. Maybe in after 2 months it will be out.
They're having, I think there are different needles. They are there, but I think the OPU needle is, there's the advantage is that it's a bevel shape, so it's very nicely you can have that.
Absolutely.
And there are the marking over there. So you can have that idea up to which depth of that PRP needle is going.
Yes.
Yes. Now, after embryo transfer, progesterone, how much, how long, which route? We all can share our views, because we are now sitting in a panel to come to some consensus. At the end of the day, we may change our protocols, we may change ourselves for improvement in our pregnancy rate. So, who would like to take up? Dr. Sarabjit is there. Is he there?
I think Sarabjit has left. I think within 5 minutes, so we also wind up now.
Yeah. So, Dr. Manisha, would you like to take up?
Ma'am, I usually start from the 5 days prior to the transfer. I give it till 12 weeks of pregnancy. And I give vaginal progesterone gel twice a day till 12 weeks, and Dufaston twice a day till 12 weeks. Then I stop the gel, and if she has some factors like previous history of preterm delivery and all, then probably I continue with Dufaston till 32 weeks, because that does decrease the chances of miscarriages and threatened abortions. And that's all. Normally I stop by 12 weeks.
Okay. Dr. Charu, would you like to add on?
Yeah, I also believe in it, because progesterone is really, really helpful. And after some times, if you're using, it also helps in immunomodulation in the first 3 months. So even I continue up to 7 months, whichever the case is, but I stop the vaginal use because it is very itchy and very troublesome to the patient after 12 weeks.
Yes. Dr. Sushma, ma'am?
Actually, see, there are so many consensus that you should give up to 12 weeks, you should give up to 20 weeks. In some cases, whenever I am in doubt, I have given the patient till 36 weeks also. Most of the time, 20 weeks is enough, but some patients, I feel that the patient may land in different problems. So I continue 36 weeks also.
Dr. Niti?
Ma'am, I give oral dydrogesterone after embryo transfer with an IM progesterone till pregnancy test, and if that's positive, I give that till 12 weeks. And only in case of twins, I continue oral dydrogesterone till 20 weeks.
Yeah, that's some cases.
Dr. Parul?
We need to decide.
Ma'am, we have been giving oral and vaginal both up till 12. We have stopped vaginal now after 12 because we have seen that a lot of patients then land up in preterms also because of the vaginal infections and all those things, because there's a cast which is formed because of the vaginal installation and everything. And for otherwise till 28 weeks, we are giving oral progesterone TDS dose or BD dose, depending whether it is twins or singleton.
Actually, what we see, even though we are just discussing in this forum or even conferences also, what I have seen, when I see the files, everyone has given till 36 weeks.
Actually, I think till 12 weeks, or maybe when you see a placenta, I use a practical tip. When I see a placenta, put a Doppler on it, and if you see a very good vascular supply and there is no irritability in the uterus, I think we can stop progesterone, like maybe natural progesterone, and we can put them on medroxyprogesterone, weekly injection, which we used to use before, and that is working wonders. So I think that is my protocol. I would like to pause.
You will give up to 36 weeks?
Yeah, 36. IVF pregnancy, yes.
Because generally for IVF, we don't want to lose where patient should not land in preterm labor.
No preterm. We
That's
don't
why
want preterm.
See, I have seen many files coming across, and I've seen everyone has given up to till
we generally stop everything by 16 weeks, because we think that 14 to 16 weeks, as I said, we see the placental thing, Doppler study, everything appears good, we stop that, put them on medroxyprogesterone.
Yeah, and
that time we stop all injectable vaginal.
Yeah.
Sorry.
The case should be individualized also.
Yes.
Whatever the problems the patient is having.
Yes.
Accordingly, we can plan.
Next question. I think only 2 or...
Yeah, we can just now
we need to wind up. Next, please. Estrogen therapy.
Okay, Manju ma'am, you can just tell in only you can tell in one line. That is better.
Cervical tightening for all. Estrogen therapy in FET cycle. What we generally do is like there is a very good study which I had come across, that estrogen, we all used to think that you have to step it up. But a very good study which I had read recently, just yesterday, that this step-up protocol of estrogen in FET cycle is giving less cumulative pregnancy rate than a fixed dose regime. And in fixed dose regime, suppose if you are starting with, I generally do all FET cycle, I don't do natural cycle. So in this, if I'm giving, suppose 8 milligram per day, I continue this till the day 9 of the cycle, then do an ultrasound. If very good trilaminar pattern is there, I continue the same dose. If suppose endometrium is not looking up to the mark, there is no good vascularity, we may step up the dose. So this is how I practice, and that study also was suggesting the same thing. Next, please. Heparin, everyone gives and everyone knows about it. Next, please. I think last was a cervical tightening for all twins of IVF. Twins of IVF, Parul. No,
ma'am. We are measuring the
I'm a big fan of tightening, you know. I always say stitch in time saves time.
Yes.
So that stitch in time will save your 9 months of that baby. And no prematurity, no premature baby need to be born with IVF. Because mother's womb is the best incubator, costless, most economical, and most baby friendly. So I think for me, I generally give to all twins of IVF, may not be for otherwise.
And do you prefer for singleton pregnancies also? Cervical tightening?
Singleton, if she has some pain, we may have a like a gentle PV examination or ultrasound guided cervical length. If you see little bit of funneling or the progressive decrease in the size, that 16-week scan is only for cervix. So we generally do a 16-week scan, and any small short cervix I would like to put rather than half in cervix I am going to put.
Some studies have quoted if there is a previous history, then also we can do for singleton pregnancy, and when the cervical length is less than 2.5 centimeters, by ultrasound is the criteria where we should go. But some people in that case use higher dose of progesterone. That there are 2 schools of thought for both the things, because sometimes even if you do very meticulously, there are chances that amniotic fluid may leak or chorioamnionitis may occur and the patient may have sudden pain. So these are the criteria. So there are two schools of thought: invasive or just giving progesterone, which should be given at least till 8 months. So the uterus is quiet till delivery. So there are two schools of thoughts according to me.
We are doing scans at 16 weeks and we are seeing the cervical length.
Yes, that is
the
perfect.
best thing I think.
That is the best
Go
thing.
ahead with.
Because we don't do a 16-week scan otherwise.
Yeah.
12 weeks NT and then anomaly and echo. So it's better we all fall into the practice of IVF pregnancy 16 weeks for cervix. So that we have a better like evidence-based thing if you're putting a stitch.
Yes.
Dr. Anything else you would like to add?
I don't put the cervical cerclage for all patients, ma'am. Just like that, I'm doing a scan at 16 weeks only, and if need be, then I put. Otherwise, I don't usually put.
So
many times we are doing a prophylactic stitch also for the patients who have had a history of preterm or something, even if the cervical length is good enough at 16 weeks.
Correct.
We are putting at 14, 15 weeks, we'll just see the cervix, but still we are going to be doing a prophylactic cerclage for them.
Yes, similarly, if patient has recurrent abortions, maybe first trimester, because you are dilating, then taking it out. So it's better like you put a stitch. So maybe individualization of case, not a blanket thing, but be vigilant for the cervix also. Next, please.
Many times. Can you just now wind up because it's 8:45?
Yeah, the slide is here. Thank you so much. Hope you all enjoyed the panel.
It was a unique webinar and everybody enjoyed. Actually, sorry for in this because what happened, there is no one to give vote of thanks. I am doing that job. So I was busy in that, just answering all the phone calls. Okay, now, so really we have witnessed a wonderful webinar. I think before that we'll have the
winners of the quiz.
Winners of quiz, please.
Yeah, I'll just let everyone know So the winners for the quiz
please announce.
Today are Dr. Shishir from Hyderabad.
Oh,
congratulations. Dr. Ankita from Bhopal.
Okay, very nice.
Okay.
From all
Dr.
over.
Nidhi Khetan from Gorakhpur.
Oh,
okay.
And Dr. Neeraj from Delhi.
Very good.
Huge congratulations to each one of you.
Yes. Good.
And it tells us, Sushma ma'am, that the IFS with that chapter webinars are famous all over the India. Everybody is even
out of India also. Yeah, and along with Punjab chapter also, this is also there.
Yes, ma'am. It's wonderful to see that pan-India people have joined and have taken. That's wonderful.
Yeah.
Thank you so much. And at the same time, sorry for little hitch in my starting my presentation.
No problem.
Connectivity was going and coming, and that was a reason I could not come in.
No problem. It happens with everyone. We'll have one group photograph, Corona people. Just.
Yes, ma'am.
Say cheese.
Yes, cheese.
Cheese. Cheese and chicken.
Yeah.
No, I'm vegetarian. Please don't say so.
Today is Tuesday, Dr. Sarabjit.
I'm vegetarian, pure vegetarian.
Done.
Okay.
Done.
Yes,
Shravan month is going on. Don't say
yes. Chalo. Thank you, Sushma.
Thank you so much
for making this.
Thank you, ma'am. Wonderful panel. We had a wonderful opportunity.
Okay,
Thank you, Sushma ma'am.
Just wait. Let me complete my job.
Okay.
To protocol. So, thanks to everyone for wonderful contribution. So, our opening batsman, Dr. Sachin Dalal, really explored the letrozole in a wonderful way. Abhar. Dr. Manjit Kaur gave practical insights on the use of gonadotropins. Shukriya. Dr. Neha Lal, really, she has really graced the session in a different way by framing the different questions. Dhanyawad. Now, Dr. Manju and Dr. Anupa, really what to say? It was really amazing. What the Dr. Sabarjit was, I think you must be, sir, feeling like the same thing, that what we are in your mind, that it should be like that. So he was framing the same things which you are discussing with me. There should be some different hatke discussion. And you really did wonderful job. So myth breakers sessions in IVF was really broke all the confusions. Tons of thanks. Then Dr. Charu Baheti, Dr. Manisha, Dr. Neeti Chabra, Dr. Shalaka Mamidwar, all were really participated wonderfully. Dr. Shwetananda, Dr. Pranita couldn't participate, but this only 4 and after 3 with 2. There's a famous 5. They did the job wonderfully. Thanks a lot.
Thank you, ma'am.
Thank you,
Thank
ma'am.
you so
Thank you
much.
so
You
much.
are always so appreciative. We love that. We love to be
Gracias.
part of your
In Spanish,
webinars
you know,
always.
in Spanish, they say gracias. So gracias.
Gracias.
So Dr. Neha Verma and Dr. Parul Savji, what to say about these cute girls? Really, they are always there for every programs. They never say no and are always helping us and gracing with their very, they are having very affectionate way, in a glamorous way. They are doing all the things very easy. Parul sang the song. The Neha is also working very hard behind the screen. So thank you very much. They shoulder the responsibility with each and everyone and which coordinating with all. So tons of thanks. And now Dr. Sarabjit. Really, he was discussing with me and really it was his main idea. It was though I was thinking about some different aspect like drugs and all this, but then he said, we'll have this session like myths and all this thing. So thank you, Dr. Sarabjit and Punjab chapter, along with also our Delhi chapter, who is giving us opportunity to discuss and communicate with all the people from all over the India, even across the world. And also our NOGS and the Corona, who has given us the platform. Thank you very much. And really, tons of thanks to all. Really, it was an amazing webinar.
Thank you, ma'am.
Thank you so much for appreciating.
I enjoyed being a panelist to your panel even.
Now you can speak. Now all can speak.